Thank you, sir. Thank you, organizers, for inviting me, and a very good afternoon to all my colleagues. So, I was asked to talk about parasitic infections. Where do you find them? And on this topic, I would be rather more focusing on how to find them. So, these are my necessary disclosures before I move on to my talk. I do not have any conflict of interest with regard to this talk. And this would be the outline of my talk. First of all, I would be classifying the parasites, and then I would be presenting some cases. And in the interest of time, what I've done is actually I have focused on one particular syndrome which is caused by the parasites. So I would be mainly focusing on the hepatobiliary and the GI syndromes. So first, let's look at what are the parasites and how do we classify them. So parasites are the organisms that live on or in a host and gets its food from the host. And based on the CDC classification, they are classified into three different types. First is the protozoa, which are the single celled. And based on their motility, they are further subclassified into four different types, namely Sarcodina, that is amoeba. And then Mastigophora, the flagellates like Giardia and Leishmania. Then Celiophora, the ciliates like Balantidium. And the last one is the Sporozoa, the organisms whose adult stage is not motile. And these are Plasmodium and the Cryptosporidium. Then we have helminths, which are multicellular. And there are three main different classes of helminths. These are flatworms, that is the flukes, and the tapeworms, also known as the cestodes and the trematodes. Then we have thorny-headed worms like the acanthocephalans. And finally, we have the roundworms, also known as nematodes. And the last, we have ectoparasites. These are actually arthropods, which are blood-sucking parasites, which suck blood, and they have main role in the transmission, and they act as a vector. And these are mosquito, ticks, fleas, and lices. So this is a slide which I actually thought in my mind and prepared. There's no reference for this. And these are the various syndromes, according to me. I'm sure there are many more which are caused by the parasites. First is the liver and the hepatobiliary syndromes. These are mainly caused by Fasciola, Toxocara, Opisthorchiasis, Clonorchiasis, Ascariasis, Echinococcus, and Schistosomiasis. Then we have the CNS syndromes. There could be both meningeal syndromes as well as the parenchymal syndromes. Cysticercosis causes both meningeal and the parenchymal syndromes. Then we have some parasites which actually causes the eosinophilic meningitis. These could be Bailey's ascaris, Gnathostoma, Angiostrongylosis cantonensis. Then Toxocara, Trichinella, and Acanthamoeba can also cause CNS syndromes. Acanthamoeba and Naegleria predominantly causes the parenchymal syndromes, and they usually have a very fatal course. Naegleria is sort of an acute presentation, whereas Acanthamoeba is more of a subacute to chronic presentation. Then we have cutaneous larva migrans. These are predominantly caused by Ancyclostoma, Nicator americanus, strongyloidiasis, which we very commonly see in our ICU, especially in those patients who have been exposed to high-dose steroids for a prolonged courses of time. They many times present with bloodstream infection due to a gram-negative bacilli or a meningitis due to E. coli or a Klebsiella. So whenever we have a patient who has presented with that syndrome and we find that there is a peripheral eosinophilia, in that situation, we should always think of strongyloiditis in that clinical setting. Also, other parasites which can cause cutaneous larva migrans are Dracunculiasis, Loiasis, and then we have ocular larva migrans, which is caused by Toxocara. Then we have pulmonary syndromes, which are predominantly caused by Paragonimus, which is mainly seen in patients from Nepal. Then Fasciola, which is commonly seen in India. Echinococcus, again commonly seen in India. And Dirophilaria, which actually presents like a mass coin or a mask like a lesion, very spherical or a rounded kind of a lesion. Then we have parasites which involve the reticuloendothelial systems like Plasmodium and Leishmania. And finally, the lymphatic systems is involved by Wuchereria, leading on to development of filariasis. So this is actually a classification. This actually has no reference. This has been created just by me for my understanding. And in the interest of time, because we have only 15 to 20 minutes to discuss, I would just be focusing on the liver and the hepatobiliary system syndromes. And for that, I would be discussing my first case. This is a 40-year-old female who presents for 2 months history of fever. Along with that, she has involuntary weight loss and right upper quadrant pain. She has no significant past medical history. Clinical examination, she has pallor and she has hepatomegaly. There is no other positive finding on clinical examination. Her basic lab workup was normal. KFT, LFT was normal. Viral markers were negative. Ultrasound of the abdomen showed an hypodense lesion in the liver, and the CBC report highlighted that. Do we have point? Highlighted that there was marked peripheral eosinophilia. We can clearly see that the eosinophils were 25% in this patient. So, based on the ultrasound finding, we went ahead and did an MRI of the abdomen because the patient had a past history of a contrast allergy. So, in this MRI, the very interesting report and very interesting images, we can clearly see the post-contrast images, which shows there is a conglomerated cystic lesion located around the porta. And if you look at the image on the right-hand side, you can even see a linear tract in this image. So this was same thing was also concluded by the radiologist, who also felt that these are conglomerated cystic lesions, mainly around the porta, and there is a linear tract, and the possibility of visceral larva migrans needs to be considered. So summarizing the case so far, this is a 40-year-old female who presents with fever, weight loss, right upper quadrant pain, has anemia, eosinophilia, and a hypodense liver lesion. So differentials in this setting are very few and very clear. The first and the foremost in the Indian setting is fasciola, which is the liver parasite, which actually is caused by the consumption of contaminated watercress and many other green leafy vegetables which can be contaminated. They can also spread fasciola. Then we have toxocariasis, and then we have opisthorchiasis, which can also present in a similar manner. But opisthorchiasis is mainly seen in the Russian and the former Soviet Union countries. It is epidemiologically not very common in India, although I recently had a case of opisthorchiasis, but that patient had spent considerable amount of time in the Russia. Then we have clonorchiasis, which again epidemiologically is not present in India. It is the Chinese liver fluke, mainly seen in Far Eastern countries like Japan, Southeastern China, Laos, Cambodia, Vietnam. Then also ascariasis can also present in a very similar fashion. So considering the parasitic pathology, we sent out a stool sample that was negative for ova and parasites, and a liver biopsy was performed at this point, and liver biopsy was suggestive of eosinophilic infiltrates with charcoal leaden crystals in that, and that also pointed out to a parasitic pathology, but it actually did not give us any clue about the diagnosis. So further moving on, we did an ERCP and we aspirated the bile and sent to the lab for analysis. And we found that there was an operculated egg which was seen, and this actually confirmed the diagnosis of fasciola based on the finding of this operculated egg, which actually was matching with the size of the usual size of the fasciola egg, which we routinely see, that is 120 to 160 micrometer and around 60 to 80 micrometer wide. So just to sum up on one slide, this is a patient who had an infection due to fasciola. On the top, you can see the organism, formalin stained fixed organism of fasciola. On the other hand, you have a watercress, which actually is the causative route for getting an infection from this pathogen. Then the lowermost on the right hand side, you have the ERCP image of a fasciola. This actually is not from this patient. This is from Google. And the other hand, you have the operculated fasciola egg, which actually confirms the diagnosis. So this is basically the life cycle. I will not go into this into the interest of the time. So basically, the clinical presentation of fasciola is in two phases, the acute phase and the chronic phase. The acute phase is from 6 to 12 weeks. And this usually is for up to 12 weeks after you have ingested a metacercaria. And in this phase, you have fever, right upper quadrant pain, hepatomegaly, and jaundice. And there is a marked peripheral eosinophilia in this stage. Because of this being a parasitic, and there is a lot of immune-mediated phenomena are also seen in this pathology. You can see Loeffler syndrome, you can see eosinophilic pneumonia, you can have hyperreactive airway disease, and you can also trigger urticarial dermatosis in this subset of patients. Then you have a chronic phase, which lasts from 6 months to 10 years. And in this, the disease is predominantly biliary because the worm finally goes into the CBD, dies over there, and actually leads to obstructive symptoms over there. Because of that obstructive pathology, We very commonly see these patients presenting as cholangitis and pancreatitis, and also a few cases of ectopic fasciolitis in terms of involvement of lungs, bones, even brain have been reported in the literature. You can get pharyngeal fasciolitis if you consume liver from an infected animal. So that also has been reported, and this is commonly seen in Middle Eastern countries. So diagnosis is based on when we confirm the findings of eggs in stool, duodenal aspirates, or the bile specimens. Eggs are not identified in the stool in the acute phase. Liver biopsy can be just done to rule out other pathologies like malignancies and all those things, but it rarely demonstrates eggs or the adult flukes. Serology is very helpful in acute phase because we usually do not see the eggs in the acute phase of the disease. And the problem with the serology is that it is actually not available. I have stored sample of 8 patients, which I am trying to ship to CDC with help of Dr. Christina, who I happened to meet during the Top Med course in CMC Vellore. So I'm trying to organize that, but we do not have access to fasciola serology in India. The fasciola serology is based on an immunoblot assay, and it targets the fasciola hepatica antigen FHSAP2. And the sensitivity and specificity of this antigen assay is very good. It is the sensitivity is 94%, the specificity is 98%, and it becomes positive as early as 2 weeks after the onset of the infection. So in this case, the struggle did not end here. We have made a diagnosis, but we have to treat the patient also, because that's what we do as a clinician. So we tried to procure triclabendazole. Again, it is not available in open market. We had to write to WHO, and they were very considerate enough to help us arrange triclabendazole. This actually is sourced from their head office in Geneva to their Delhi office, and then finally delivered to me or to the patient directly if the patient is willing to provide the address and willing to provide the cost for it. They provide this medicine free of cost, and they use, whenever you ask for 1 dose, they are very considerate enough to provide you 2 doses. So they usually, instead of 4 tablets, they would provide either 8 or 12 tablets for 1 patient, so that you can help other patients if you have anyone. This is associated with very high cure rates, and more than 90% cure rates have been recorded in studies from Peru and Bolivia, where it is very commonly seen, much more common than in India. Nitazoxanide is an alternate. We have had very good experience of using nitazoxanide in our patients. The dose is pretty straightforward. It is 500 milligram BD for 7 days. And the cure rates are not as good as triclabendazole, but it is easily available. You can use it. The cure rates from the same Peruvian study is in children is 40%, and in adults it is 60%. So this is my experience of last 3 years at Medanta. I had seen 8 cases of fasciola hepatica. I would rather call fasciola, not fasciola hepatica. 3 of the patients were females, 5 males. The mean age was 38 years, and the clinical presentation is the same as we see for the most of the cases: fever, right upper quadrant pain, and a weight loss. They had marked eosinophilia, and all the patients had eosinophilia of more than 20-25%. And the radiology in almost all of the cases were very consistent: lesions around the porta hepatis, and there were linear tracts in the portal triad. The LFT abnormality were not very common. They were seen in only few patients. Few of them had raised bilirubin, few of them has raised alkaline phosphatase, and mild transaminitis to go with. The definitive diagnosis based on the identification of the eggs in either a stool or a bile was made only in 3 patients. 5 of them had presumptive diagnosis based on the compatible clinical syndrome and a radiological picture and an eosinophilia of more than 20%. We treated 5 patients initially upfront with nitazoxanide because they were actually not willing to wait for the time which is taken to procure the triclabendazole, which actually takes around 3 to 4 weeks. Out of those 5 patients, very interestingly, 4 of them improved. Their eosinophilias normalized, their fever settled, they started to gain weight, and the LFT pattern also started to normalize. One of them had actually had a relapse. He also improved initially and then relapsed, and that patient also subsequently was treated with triclabendazole. We treated 4 patients out of the total 8 patients with triclabendazole. Out of that 4, one was a relapse case, and all of those 4 patients improved, and none of them actually have relapsed till now, and with a median follow-up of around 6 months. So if they have to relapse, actually they relapse within a month of stopping therapy with nitazoxanide. They relapse very quickly. So the one patient who relapsed, once I stopped therapy with nitazoxanide, within 3 to 4 weeks, he came back with similar symptoms and the eosinophilia going up again. So quickly going into the second case, this is a 50-year-old female, presents with cough and a mucoid expectoration for 1 year, is right upper quadrant pain for 3 months, and is an involuntary weight loss of 10 kgs over 3 months. This clinical examination again is very unremarkable except for right hypochondrium tenderness, and his labs are also grossly unremarkable. LFT was also normal, viral markers negative, basic CBC, creatinine electrolytes normal. The chest X-ray was a very interesting, and there was a solid cystic kind of a lesion in the right parahilar region, which was confirmed by a CT, and this actually was reported by the radiologist as a cystic lesion in the right upper lobe. Probably they had commented that this could be a parasitic infection in terms of hydrated disease, was their first differential radiologically. So since we were thinking about hydrated in this patient, we did an ultrasound of the patient, and not to our surprise, and also there was a clinical finding that there was a right hypochondriac tenderness also was there. So we did an ultrasound of this patient, and we found that there was a large cystic lesion with floating detached membranes. This is a classical hallmark of hydrated disease of CE3A staging, of Garby staging as per the WHO. Then we confirmed that finding with the CT scan. In the CT scan, you can clearly see that there is a large cystic lesion. Along with within that cystic lesion, there are floating membranes, and some of those floating membranes have actually detached. So this is a kind of a water lily sign which we see in CE3A stage of the hydrated disease. Just for our academic interest, because one of our radiology PG was doing thesis on cystic liver lesion. So we did an MRI abdomen, although it is actually not recommended for doing MRI for hydrated disease. So we see that you can clearly see that the membranes actually are hypo-intense, and the cyst is very hyper-intense when you see on T2 weighted images on both coronal and axial views. So very nice images. If you just look at the images, the best images are actually given by the MRI. But if you just go by the guidelines, this MRI is actually not recommended for a hydrated patient. You do an ultrasound, because ultrasound is the main, and it actually forms the backbone of the treatment. It's not just diagnostic. It actually helps you plan your therapeutics, because the management depends on which stage of hydrated you are dealing with. So this is a WHO prescribed Garby staging of the hydrated disease, and this is based on an ultrasound staging. This is not based on CT findings or an MRI finding. CL is a simple cystic lesion, and CE1 is a cystic echinococosis, in which you will just see that there is a simple cyst. And if you ask the patient, you can see some sand or something moving in that. Basically, those are hydrated hooklets. They are seen in around 50% of the cases in this CE1 stage of the patient. Then you have CE2 stage. In the CE2 stage, you can see that there are multiple daughter cysts inside a large cyst, and it gives you an appearance of a honeycomb pattern. This honeycomb pattern is seen in CE2 stage, and this is the CE1 and CE2 are the two stages which are the active stages. Then we have CE3 stage, which is actually divided into two parts. One is the CE3A and CE3B. CE3A is the stage in which you have a daughter cyst inside a cyst, and the membranes have detached from the surface. So here you can clearly see that there are membranes detached, and there is a water lily kind of a sign you can see in the CE3A. CE3B, you actually starts to see some calcification in that. So some amount of calcification along with some daughter cyst being visible is CE3B. CE4 and CE5 are inactive stages of the cyst, and they are calcified cysts in various stages, and they actually do not need any kind of treatment. So the treatment of this hydrated disease is based on the staging of the hydrated disease based on the ultrasound. If you have a CE1 stage, And if the size is less than 5 centimeter, you can just give albendazole. If the size is more than 5 centimeter, in that situation, you need to give a combination of a medical and a surgical management. In this, you give albendazole and you do pair procedure. I will talk about pair later on. And then you have CE2. CE2 is the one which would need surgery or some kind of modified catheterization. CE3A is if you have a cyst of less than 5 centimeter, then you give albendazole alone. CE3A of size more than 5 centimeter, albendazole plus pair. CA3B, again surgery, and CE4 and CE5 is just observation. You don't need any treatment.
Because you can sum it up.
Sure, sir. Pair is percutaneous aspiration, injection and re-aspiration. You can use either ethanol or hypertonic saline. Albendazole needs to be given prior to the 4 hours prior to the procedure, and you can continue for 1 month after that. Pair is only for CE1 and CE3A, and this is, I will not go into this. So coming back to the case, he undergoes pair, and in that, if when we analyzed the aspirate, we found there were hydrated hooklets in it. And he also undergoes a lobectomy because he had a pulmonary involvement, and very nice specimens, very nice pictures provided by our thoracic surgeons. You can clearly see that hydrated, the gross morphology of hydrated cyst. That same was confirmed by the histopath people. He receives albendazole for 3 months, although now there is some evidence to support a combination therapy of albendazole plus praziquantel based on studies from Peru and Uruguay. So to sum it up, parasitic disease, they present as a significant burden in tropical areas, and they form the largest number of diseases in that WHO neglected tropical diseases. Whenever we are dealing with these kind of diseases, we need to have a high index of suspicion to keep them in our differential diagnosis, and they pose as a significant diagnostic challenges to us because many times the diagnostic modalities and the tests are not available to us. Therapeutics also is very poorly understood, and vaccine for these diseases is still under development. In many of these, actually the vaccine is available for animals, but not for humans. So I invite you all to our annual national conference, which is in Kolkata this year. And thank you, and I'm open to take questions. Thank you.
Thank you for giving a very enlightening us with a new disease, fasciola. We have never seen a case like this, but I'm sure you have already seen 8 cases. Some of the people in the audience must have also seen some of these cases. But thank you very much once again, sir.
Thank you, sir. Sure.
I think there are no questions. We move on to the next topic, fungal infections in HIV. I request Dr. Parikshit Prayag to come and deliver the talk, and Dr. Jatin Ahuja, ID consultant from Apollo, to chair the session.
So good afternoon, everyone. So today, Dr. Parikshit is going to present on the fungal infections in HIV. As we know that as we see the patient of HIV, they are immunocompromised, and as the CD4 goes down, there is always a tendency to catch a number of infections, whether it's a viral, bacterial, or fungal. In fungal, it's basically as simple as oral thrush and as complex as many dimorphic fungi. And in our country also, we see sometimes the telromyces, mainly in the northeastern regions. So with that, I'll over to the Dr. Parikshit for his presentation. Thank you.
Thank you, sir, and good afternoon, everyone. And first of all, thank you for having me. Thank you to Neha and thank you to Vikas. It's lovely to be here with all of you. And I hear this is the first official SIDS program in North India. So just as Neha has been pioneering infectious diseases in this part of the country, she has also been pioneering CMEs in this part of the country. So that is great to hear. So I've been given the responsibility of talking about fungal infections in HIV. So this, as sir mentioned, is a broad topic. One interesting aspect of HIV patients is, when you talk of opportunistic infections or when you talk of infections in immunocompromised patients, we have to ask ourselves what arm of the immunity is affected. So, an immunocompromised patient is a wide spectrum, right from, pregnancy or uncontrolled diabetes to someone who has had an aplastic anemia and has undergone an haploidentical transplant, has failed the transplant and has undergone another transplant. So this is really the spectrum of immune suppression. When we see a patient with us, we have to ask ourselves where along this journey does the patient lie. So if you look at HIV patients, one important aspect here is that not many of these patients actually have neutrophilic dysfunctions until very late in the disease. When you talk about immunocompromised patients and HIV patients, most of the immunological dysfunction comes from T cell mediated processes. And that's where the spectrum of fungal infections is very different from, let's say, a leukemia patient or a patient who has undergone a bone marrow transplant. So usually what you will see is a lot of endemic mycosis, a lot of fungal infections which have a lot to do with T cell dysfunction. Rarely will you see disseminated candidemia, what we see in neutropenic patients, or even molds till the CD4 is very, very low. So that sort of spectrum is very different. So each immunocompromising condition has its own spectrum with us. So having said that, it's not possible to cover all the fungal infections in HIV patients in the span of around 20 to 25 minutes. So through 3 or 4 cases, I will try to go through this journey of fungal infections in HIV patients. So my first patient is a 43-year-old male who has had fever and dry cough now for 10 days. He comes to us and is newly diagnosed as HIV. So often, nowadays, because of the developments in ART, we often see patients who are newly diagnosed with HIV presenting with opportunistic infections. Later in the course, as their disease is controlled, we see fewer and fewer opportunistic infections. So this is a patient who is newly diagnosed with HIV-1. He's not on antiretroviral therapy at this point of time. His CD4 on diagnosis is 74. He has mild leukopenia and he has a slightly higher LDH, not emphatic by any stretch of the imagination. He's saturating 87% on room air. His LFTs, RFTs are all within normal limits at this point of time. So this is an HIV patient, newly diagnosed HIV. CD4 is 74. He's coming to you with dry cough and fever for 10 days. Now, even amongst the HIV patients, the commonest causes of pneumonia still remain community acquired processes. Just because this patient has HIV, you should not jump to the conclusion that he might have a PCP or he might have a cryptococcal pneumonia or he might have TB. Absolutely important differentials to be considered. So pulmonary affection in HIV patients, especially who have a low CD4 count, these are important differentials. But the important message is that we should never forget our good old community acquired processes. World over, if you look at HIV studies, strep pneumo still remains a very, very important pathogen in these cases. So, these often immunocompromised patients have etiological factors or differentials in addition to what we consider in the immunocompetent patient. So we should never forget what we would have considered in a healthy, normal individual. Otherwise, we would have definitely gone into the history, looked at risk factors for Klebsiella, looked at hospitalizations, looked at risk factors for strep pneumo, looked at post-viral infections. So all these things need to be done even in our immunocompromised patients. So when we got a CT scan of the chest, his CT scan of the chest showed nodular ground glass opacities bilaterally. You will see that there is some sort of a predominance in the upper lobes and there is a little bit of peripheral sparing here. So if you look at this type of a CT scan, what would you think of as your most important differential? Anyone? PCP, right? So PCP would be an important differential. Now these patients often can get other differentials for their bilateral interstitial infiltrates. You can have upper respiratory infections which can go on to involve the lower respiratory tract. We can never forget COVID. This is by no means looking like a classic CT scan for COVID, but rarely they can have influenza, para-influenza, which can go on and involve the lower respiratory tract. CMV again with bilateral interstitial infiltrates, although HIV patients until very late in the spectrum of the disease usually don't develop very severe CMV pneumonitis, but this patient has a CD4 of 74. So that would be an important differential. And, again, as I said, our atypical pathogens in the community, Mycoplasma, Legionella, someone who is presenting with 10 days of fever and dry cough, newly diagnosed with HIV and has a CD4 of 74. Now, this panel is not very clear, but this is a BioFire lower respiratory PCR panel. So we did a bronchoalveolar lavage, and the lower respiratory PCR panel actually shows E. coli and shows resistance markers as WIM. So WIM is a class B enzyme. So it's like the New Delhi metallo-beta-lactamase. So his lower respiratory panel, when we do the bronchoalveolar lavage, is actually showing E. coli. So how many of you think that E. coli would be an important pathogen in this setting? Would you be comfortable putting this? So this patient now is requiring about 4 liters of oxygen at this point of time. So he requires 4 liters of oxygen, is saturating around 90 to 92%. Again, his background is 10 days of fever and dry cough. CD4 is 74, newly diagnosed HIV. And now in the lower respiratory panel, we have E. coli, which is showing a resistance marker. So it's showing the class B enzyme. So if you had to treat this E. coli, you would have to probably use a polymyxin backbone, or, depending on if he's producing any other enzymes, add something like avibactam-2 and aztreonam backbone with the class B enzymes. But do we all need to do this? So how many of us really think that, E. coli is the true pathogen here? So it would be very rare to have someone presenting from the community, no risk factors for aspiration. This is not a patient who has had a ventilator associated pneumonia. There is no E. coli bacterium at this point of time. So E. coli would be a very, very odd pathogen in this setting. So this is another case, as we expand our microbiological diagnostics and as we get a lot of panels for a lot of syndromes in clinical practice, we need to really take these in the clinical context. So by no stretch of the imagination should our hunt for a bug end at this point of time. So this PCR panel is showing an E. coli, which is a resistant E. coli. However, see what's given on the right side. His BAL galactomannan is negative. His BAL silver methenamine stain for PCP is negative. His CMV PCR is negative. His BAL gene expert is negative, and his respiratory PCR panel shows an E. coli, which is resistant to carbapenems. So now we have said that, we have sent tests for aspergillosis, we have sent a stain for PCP, we have sent a CMV PCR, both in the blood as well as in the BAL. We have sent a BAL gene expert, which is negative. Now, all of that has been negative. All our other workup has been negative. Would at this point of time, out of desperation, would you start something like polymyxin on this patient, or you would still want to go for further diagnostics at this point of time? Further diagnostics? Anything else that you would like to do? Yes, sir. Lung biopsy. Okay. That would be the best. I mean, if we do get a lung tissue, it would be the absolute best. BDG. So BDG would be one important thing, and we'll talk about this. Anything else that anyone would like to get on this patient? PCP PCR, right? So then let us look at, the stains for PCP, and let us try and ask ourselves that if someone has a negative PCP stain, so we talked about the silver methenamine stain, would that rule out PCP? Now, stains are good for PCP. Why? Because they have very high specificity, which means that if my silver staining on this specimen would have been positive, I could have ended my search for an organism there. So I would have been confident that this is indeed PCP. However, sensitivity is not 100%. So in the best of situations, so the sensitivity is slightly higher in HIV patients, wherein it is slightly higher in the BAL specimen compared to an induced sputum or to a sputum. So my sensitivity would be around 70 to 80%. Again, lower in non-HIV patients and lower in non-BAL specimens, but the specificity is high. If you compare that with fluorescent stains like DFA, again, their sensitivity is slightly higher. Now, I have done a silver methenamine stain on a BAL specimen. So it has a sensitivity of around 70 to 80%, which means that 20 to 30% of the times I could still have PCP with this type of a picture. And so at this point of time, I need to ask myself, is this presumed PCP? Which means that, is this the right kind of clinical setting for a lot of opportunistic infections? And for most of the times in mycology, the first question begins with, is this the right kind of setting for this organism? So is this the right kind of setting? It is. This is a patient who is a newly diagnosed HIV patient with a CD4 of less than 200. So his CD4 is in the 70s. He has clinical signs and symptoms which are compatible with PCP. So he has had 10 days of fever and dry cough, and he has had a CT scan which is showing nodular ground glass opacities with peripheral sparing and a predominance in the upper lobes. So now what we must do is, as Neha mentioned, we have to send an we have to send a beta-D glucan. So what is beta-D glucan? It's the component of the cell wall of many different fungi. And if you look at the mycological spectrum, then, Candida, Aspergillus, PCP, these would be more associated with a positive BDG. So what is a presumptive diagnosis of PCP? So it is so sensitive, this beta-D glucan, that it is a good test to rule out PCP, especially in HIV patients, which means that if my BDG would be negative, then I would definitely need to look at other differentials at this point of time, because then I would have a patient who has had a negative stain and, more importantly, a negative BDG. then I cannot be fixated on the idea of PCP. Then definitely I need to widen my search for an organism, as sir mentioned, maybe even contemplate getting a lung biopsy at this point of time. So a presumptive diagnosis would be someone who has the right clinical and radiographic setting and has a positive BDG. The other thing which we can do is a PCP PCR. So we have to remember that it is definitely more sensitive than staining method. So the sensitivity can approach around 90 to 95%. In some studies, it can even be close to 100%, especially in the bronchoalveolar lavage. The one thing that the PCP PCR suffers from is its inability, like with most PCRs, to tell us whether this is colonization or true infection. Which means that if I have a patient in whom the PCP PCR is positive, I really don't know whether this is a colonization or this is a true PCP. That is when I put all the clinical picture into context. However, here we have quantification which can help us with distinguishing between colonization and true infection. So, if you look at most of the studies which have been done with a quantitative PCP PCR, they have looked into the cutoffs for quantitative PCR. So they have found a uniform pattern wherein, true infection is associated with much higher loads of the PCP PCR. So just as you have viral loads in COVID, or just as you have cycle thresholds, the cycle thresholds are inversely proportional to the organism load. So these cycle thresholds, depending on the kit that you are using, can actually tell us, what is the approximate number of organisms which are present there. So when you have this type of picture, always talk to your microbiologist and always discuss with him, is this quantification more likely to represent colonization, or is this quantification more likely to represent a true infection? And this is really a good study in which they showed that, if you have cycle thresholds which are below 34, then you are more likely to be looking at true infection. As I mentioned, cycle thresholds are inversely proportional to the organism load which is present. Especially when you combine that with a positive BDG, then it is very easy to establish a proven diagnosis of PCP, which means that I have the right kind of clinical radiographic setting, my BDG is positive, and then my PCP PCR is positive, then regardless of the cycle threshold, this would be a proven PCP. But if I don't send a BDG, then I have to be looking at the quantification of a PCP PCR and trying to interpret it in the clinical context and trying to interpret it quantitatively. So again, more than 34 for most kits would be a little suspicious for colonization. So back to our patient, what we did was at this point of time, sent a serum beta D glucan, which was more than 523, which is the upper limit of the assay. So it is strongly positive. So now our patient fulfills the criteria of presumptive PCP because he has, as we mentioned, the right kind of a clinical picture or the clinical setting. HIV patient, CD4 of 74, bilateral infiltrates, nodular ground glass opacities, peripheral staining, and now also has a positive BDG. So this establishes the diagnosis of, a presumptive diagnosis of PCP. Again, to be sure, you need to prove that this is PCP because as we mentioned, a BDG is sensitive, but it may not be specific. In this type of a setting, more than 9 out of 10 times this will have to be PCP. But his PCP PCR on the bronchoalveolar lavage was then positive. So this is, sort of an in-house algorithm that we follow, in our settings. HIV with a CD4 count of less than 200. Clinical picture is suspicious. Radiographic picture is suspicious, which means that you have the right kind of clinical setting for getting PCP. And now you have a clinical and radiographic picture. One important test would be to start with a BDG. If your BDG is negative, then immediately you need to look for other diagnosis because it is so sensitive that a negative BDG in this type of a setting would help you rule out PCP. So if your BDG is negative here, definitely look or work up for other causes. If it is positive, then he will have to be treated as presumed PCP or presumptive PCP, but we still need to establish a proven diagnosis by either getting a PCR or a stain, and a PCR is more sensitive than staining. So this is in a nutshell how we approach diagnostics for PCP. Now coming to the management part, what the most important question is, there are 3 questions here. What are the drugs that you will use for PCP? How and when and in whom will you use steroids and for how long? And the third part is, when will you start this patient on antiretroviral therapy? These are the 3 important questions now that we have established the diagnosis of PCP. Now back in the 90s, NEJM published this review of evidence for using steroids in PCP. And what they showed was that patients who had a moderate amount of hypoxemia, which means that when their PaO2 or the arterial oxygen pressure was less than 70, or when they had an elevated A gradient, then they seem to benefit from steroids. Now, this has been looked at subsequently, and this has also been looked at in larger studies, and they have been sort of showing congruent results that patients who have moderate to severe hypoxemia do benefit from steroids in the long run. The mortality reduction is about 40% at the end of 3 months, and it is sustained actually at the end of 6 months to 1 year. So that's why the current guidelines or the current criteria for using steroids in PCP is anyone who has a moderate to severe hypoxemia. So anyone who has a PaO2 of less than 70, we do use steroids in these patients. Now, if someone has mild hypoxemia, does it mean that steroids are not warranted? Probably they are still beneficial, but the benefit is not so large as to give them in a patient who has a CD4 count of 74. So that's why all the guidelines recommend using steroids in patients who have moderate hypoxia. By that we mean PaO2 of less than 70. So that's when we use steroids. For how long do we use them? So usually you would use steroids for the same duration as you would treat an active PCP. So you would give something like a TMP SMX for 3 weeks, and during those 3 weeks use steroids. So you can start off, the recommended regimen is to start off with 40 milligrams BD of prednisone for 5 days, then taper it to half in the next 5 days, and use about 20 milligrams OD for the remaining 10 or 11 days. So this is interesting because a drug which increases the risk for PCP is included in the regimen for saving lives in patients who have PCP. So if you look at large trials in patients who develop PCP on steroids, then generally the consistent risk factor was getting steroids for more than 4 weeks, at least getting more than 20 milligrams of steroids for more than 4 weeks. So here we use it for about 3 weeks. Coming to the treatment part, this is easy. All of us know this. The TMP SMX remains the backbone of therapy. However, there are certain interesting aspects here. So when you look at TMP SMX in the setting of PCP, what we are really using here is the SMX. Unlike in a patient with nocardia, wherein we are also to a certain extent dependent on the TMP, here we are exclusively using the SMX part of it. Now, if you look at resistance mutations, then SMX mutations are very, very rare, which means that for someone to have a dihydropteroid mutation to produce resistance to SMX, that would be very rare, and hence truly TMP SMX refractory PCP is very, very rare. Unlike patients with nocardia, in whom you do see resistance up to the rates of 5 to 10% depending on the species of nocardia. So unlike nocardia, resistance or refractory PCP is truly rare. But if you do get it, then you have to switch these patients to alternative regimens. So one thing could be something like using a pyri plus primaquine plus clindamycin. I have had one patient who failed almost all lines of therapy. So this was in the US when we gave him TMP SMX, failed it. Then we gave him Clinda and Prima, failed it. Then Atowacone, he failed. Pentamidine, he failed. And then at the end of it, we had to use high dose Bactrim plus high dose Clinda plus Prima and add an echinocandin. So remember, echinocandins have very good activity against the glucan synthase enzyme. So these are good drugs against, although they have not been evaluated in clinical trials, the original so echinocandins were originally devised with the hope that they would be able to combat PCP. So that is one thing again, but these are extremely rare cases. But in general, you do see TMP SMX refractory PCP very, very rarely. Coming to the third question, when do we start ART for such patients? Normally when you diagnose an opportunistic infection, you are worried about iris. So you're worried about, hastily starting ART in these patients. Now, PCP is one place wherein you can start ART fairly early, but provided you have ruled out other conditions which can unmask in the form of an iris. So for example, if I have a patient like him in whom I have diagnosed PCP as, an opportunistic infection presenting at the diagnosis of HIV, then I will make sure that, he does not have something like TB, he does not have something like a cryptococcal antigen, which is positive, something that can unmask when I start him on ART and become a problem later. I'm not so worried about iris from PCP. What I'm really worried about is other opportunistic infections unmasking when I start this patient on ART without that particular therapy. So as long as I have done a thorough workup, I have made sure that his crypto antigen is negative, he doesn't have any other opportunistic infections, you can start ART fairly early. It definitely should be started within the first 2 weeks. Again, here you have the advantage of steroids, which are going to be used for the first 3 weeks. So technically, your risk of iris is much lower. So if you have done a thorough workup, then you can actually start it fairly early. So even within the first 2 or 3 days, you can start ART, provided there are no infections which have been not uncovered, so as to say, which will manifest later on. So let's go over to our second case. This is a 24-year-old male with HIV, not compliant with therapy. So his CD4 is 40. He presents with headache, low-grade fever. MRI is done, which shows leptomeningeal enhancement. His CSF shows 40 WBCs, 80% lymphocytes. Proteins are 74 and CSF glucose is 43. Now you all know that we are discussing fungal infections in HIV. So you all know that this is going to be cryptomeningitis. So let us look at some of the nuances of, cryptococcal meningitis. The case was just an illustrative case. So how do we diagnose crypto? What are the differences between, getting a crypto PCR in the CSF versus getting a serum antigen versus getting a CSF antigen? So cryptococcal antigen is a very good test. It's a very good tool. It has excellent sensitivity both in the blood and in the CSF. In the blood, it tells you that there is cryptococcemia, which can actually precede the onset of true cryptococcal meningitis. So if you look at sensitivities, as well as if you look at sensitivities especially, then there is not much difference between getting a serum cryptococcal antigen versus getting a CSF cryptococcal antigen. You should be careful with false positives with certain infections, although, this is more of an MCQ rather than what you find in real life situations. So infections like trichosporon or stomatococcus or capnocytophaga. So such tongue twisters can give you false positive cryptococcal antigens, but these are not situations that we encounter commonly. One important aspect of the cryptococcal antigen. So let's say I have such a patient, I send his CSF and the crypto antigen comes out to be positive. One of the important things that should be done is that crypto antigen should not be used as something to monitor response to therapy. There are actually studies on this, that patients who were followed on a protocol of using the cryptococcal antigen as response to therapy, you don't add much and you are actually likely to create more confusion. So cryptococcal antigen should not be used to monitor response to therapy. The other tool that you have for such patients is a cryptococcal PCR. But
Dr.
now that,
Parikshit, can you please quickly summarize?
Sure. Now that you have cryptococcal antigen in most of the labs, really we don't need cryptococcal PCR to that extent. Again, it has excellent sensitivity. One place where it can be used is differentiating iris from true cryptococcal meningitis, because it has a very good sensitivity once the organism load is beyond a certain extent. Then you have India Inc. culture. You probably all know about this. The sensitivity is not as high as an antigen, of course. I'll skip the prognostic factors. I'll go over to therapy. So this we all know, is induction therapy with amphotericin plus flucytosine. In case your patient cannot get flucytosine, then you can replace it with fluconazole. Again, there is consolidation, maintenance here. One important thing is that a lot of cryptococcal studies have been actually done with conventional amphotericin, but there is a good amount of data to suggest that liposomal is comparable and is definitely safer. So, most of the times we end up using liposomal amphotericin for these type of patients. Just as we were talking about iris in the setting of PCP, this is the setting wherein I am truly concerned about iris. So a patient who has true cryptococcal meningitis, you would wait for at least 5 weeks, and these are the studies behind that. Patients who were actually started on early ART, especially when they had a paucicellular pattern on the CSF, which meant that they had fewer white cells on the CSF, they did worse. So which means that you have to actually wait for at least 5 weeks before you think of ART in patients who have cryptococcal meningitis. Then I talked about this, when I was talking about PCP, that we need to make sure that we are not leaving any infections which can unmask later on. So a patient who is newly diagnosed with HIV, diagnosed with some other opportunistic infection, I need to make sure that this patient does not have cryptococcemia. Even though he may not have signs of meningitis, this is something that can manifest later on as iris. So patients who have a CD4 of less than 100 definitely get a serum antigen. If serum has very high titers, then you can think of getting a CSF study. But you can have cryptococcemia without a cryptomeningitis, wherein you don't need to wait on the initiation of ART. I'll just quickly end by showing two slides, which are interesting cases. This is something that I had seen in my training. This is not here. So this is a patient who presented to us actually in Houston. So this is a 30-year-old male with fever and dry cough since 20 days, newly diagnosed HIV. hepatosplenomegaly, CD4 of 123, cytopenia, so WBC was 2300, platelets were 34,000, mild transaminitis, very high LDH, high alkaline phosphatase, and diffuse bilateral interstitial infiltrates, and over the next 3 days developed hypotension with a galactomannan of 0.8. Any guesses? So galactomannan is here is mildly elevated, it's 0.8. The technical cutoff would be 0.5, but so it is mildly elevated. So this galactomannan would definitely not be specific
Which
for
part of the states? Which part of the states?
Texas. Texas. Right, exactly. So this is very concerning for histoplasmosis. So histoplasma in the right clinical context can present with severe cytopenias, hepatosplenomegaly, lymphadenopathies, GI, pulmonary manifestations, and it is one fungus which can present as septic shock in patients with HIV. So again, I'll skip the theory behind histoplasma and end with this last slide or the second last slide. 30-year-old male with fever and dry cough since 10 days, newly diagnosed HIV, hepatosplenomegaly, CD4 of 30, an X-ray with diffuse bilateral interstitial infiltrates and these skin lesions. Penicillosis, right? So when you see these sort of skin lesions, you would be worried about histoplasma, crypto, penicillosis. So this patient actually was diagnosed with penicillosis. So fungal infections in HIV patients, again, to summarize, it can be a wide spectrum. We have to always ask ourselves, what arm of the immunity is affected? What are the overall risk factors? And is it the right clinical setting for this type of an infection? With Candida, you would usually see mucocutaneous infections. Disseminated is relatively rarer, although you can never say never. Mold infections can be seen at extremes of CD4 counts. So the overall clinical picture, CD4 count, virological suppression, other risk factors have to all need to be taken into account while formulating your differential. So a thorough workup is extremely essential. Again, thank you so much for having me, and I look forward to the rest of the session.
Thank you, Dr. Parikshit, for such a nice presentation. And I over to the audience for any questions. Yes, Doctor.
Yes. So, if you look at trials with PCP for steroids, they have all looked at HIV patients. But if you look at, the pathophysiology and if you look at the mortality benefit, then usually you do use the same kind of parameters even for non-HIV patients.
At one stage, hypercarbia considered as an indicator for PCP in other immunocompromised states.
Mm-hmm.
Does that still hold true, or is it only PO2 and PCO2 does not matter? Is there something?
So that can be a clue, sir, especially like you said in non-HIV settings. But now that, we have BDGs and we have much better ways of diagnosing it, but it can be a clinical clue, usually early here on. So about the second, third week, they will present more with hypoxia first and then go over to hypercarbia in the third, fourth, fifth week of the illness. But that can be a clue. But again, not very specific.
Thank you, Parikshit. That was very wonderful talk. I have one question. Now that we know that the Ambition trial results have been published. So in Ambition trial, they were actually comparing a single high dose of liposomal amphotericin 10 milligram per kg versus the standard regime. And it was actually a non-inferiority trial.
Yes.
Now, I want you to know your thoughts on that trial and what is that implication of that trial in our setting. Do we apply it or we just take it with a pinch of salt?
Right. So, for the benefit of the audience, recently there is a trial in NEJM which has shown that a single high dose of amphotericin actually can be useful or was non-inferior to, the standard regimen that we use. I showed you the standard regimens. We usually use induction dosing with 2 weeks. I think it was a fairly well-designed trial and the results are interesting. Although, personally speaking, with 2 weeks of amphotericin therapy, we don't run into a lot of problems usually. So unless there are huge financial implications, I would probably at this point of time still stick to the conventional 2 weeks and wait for better data to emerge. If Neha has any other thoughts?
No, I agree with that. And in fact, the trial had 25% mortality as
Mortality,
well.
right.
So in our clinical experience, the mortality has been much lower,
Much
just
lower.
5%.
Exactly.
So I think we need to have more data and
Exactly.
more experience.
And this is
on
not a
that.
situation like Mucor wherein you're going to use weeks and weeks of amphotericin. So this is a fairly specific setting. At the end of 2 weeks, provided your patient has an improved chemical picture in the CSF and his opening pressure is okay, you would be comfortable in switching over to the consolidation regimen. So I would still wait for more data on that one. Ambition trial.
So in ACTS trial, in the oral regimen, they use the two sides
Hmm.
and the mortality was 35% that time. Then, and if we compare the 10-week mortality, so in this trial, they use the oral regimen, two sides plus gluconazole along with single one 5 dose of liposomal amphotericin B, which is 10 milligrams per kg on day 1.
Right.
So if we compare both the trials, the mortality in the previous one was 35%. In this trial, it was 25%. But the mortality in the control arm, it was also 24-25%. So one thing is that overall care of the patient is improved because the control arm mortality was also 24-25%. Second thing is that there are two types of mortality. One is the initial 5 weeks mortality, and second is the late relapse of the patient. If you review all the articles, in all the recent articles from 2015 to 2022, there is no data on the relapse of the cases. Most importantly, is missing in most of the recent trials. So they follow the case till 10 weeks of the therapy, and they publish the data.
I think Dr. Ankesh will continue this discussion after some time, and we'll close this session.
So basically, we cannot adopt this trial
Yes.
because there is no data on the follow of the patient. In AIMS, we have seen so many cases after 3 to 4 months of therapy, on the gluconazole patient are coming with the relapse of the
Right. So what you can do is, if you're using alternative regimens, then might as well, give a high dose of amphotericin upfront. If you are going to use alternative regimens, that could be an approach.
First
But
trial
we
we
need
talk
more.
about, it was the conventional amphotericin B, I think, and the latest trial is with the liposomal.
I think what
There's also
he's trying to
differences
say
there.
is that we need to have more data on it.
Absolutely.
We can't just adopt these trials.
Yes,
And
I
we
agree
agree
with
with you completely. Another very little, I mean, it has got so many diagnostics with PCP, but on a clinical front, even PaO2 by LDH, if the ratio is more than 4, then also it goes in favor of PCP in the right setting.
Absolutely.
Thank you.
the baseline LDH was 246. So in the HIV positive patients, usually we see the sensitivity of the LDH is
Too high. Yes, it's high.
Yes.
while in the HIV negative cases it's around 65.
Yes. So it was surprisingly low in the first.
Surprisingly, in this case, it
Yes.
was low.
So negative predictive value would be again high, because it has high sensitivity. So most of the times you would expect it to be elevated. So again, but again, there is nothing which compares LDH versus beta D glucan in this sort of a setting. But it would have a high negative predictive value.
Thank you, Dr. Parikshit,
Okay,
for such a
thank
wonderful
you.
session. With this,
Yeah.
thank you. Over to
So
now.
thank you, Dr. Jatin, and thank you, Dr. Parikshit, for such a wonderful session. And from this, we move on to gram-negative infections. As we all know, antibiotics have been the bedrock of modern medicine, but we have so much of resistance in our clinical practice. And for discussing this, we have challenging cases, a panel discussion, and I invite the moderators, Dr. Omender Singh. He is the director of Institute of Critical Care Medicine from Max Saket. He needs no introduction. He has been pioneering so many and organizing so many conferences here before as well. And he has been the author of several textbooks in intensive care. I would also like to request Dr. Chandvatal to come onto the stage. Sir is one of the pioneers in microbiology. He has started off, I think, in antimicrobial stewardship, and I have also grown up during my infectious diseases fellowship. I have been hearing him, learning, and also reading his articles. The next, I would like to invite Dr. Tapesh Bansal. Dr. Tapesh Bansal is a very academic-oriented clinician. He was, in fact, the first rank and all in AIMS. And he has been the head of critical care in Paras Hospital. And now he also conducts several online academic sessions. We also invite Dr. Pooja Vadhva, who is the senior consultant in intensive care in Fortis Memorial Research Institute in Gurgaon. And now I request the moderators to invite our speaker, Dr. Nitin Bansal.
Dr. Nitin, I think, is the ID specialist at Rajiv Gandhi Institute, and we look forward to your cases.
Thank you, organizers. Thank you, Atul sir and Neha madam, to making me part of this. And I also thank them to giving me such a wonderful panelist. Before I start, I would just like to get involvement of the audience. How many of you are microbiologists here or training in microbiology? We have 2 people, 3. And how many of you are actually treating patients with gram-negative infections on a regular basis? Most of us. So these are my conflicts of interest. Some of these drugs do make antibiotics which are used in making treating gram-negative infections. But I just want to declare myself that the gram-negative infections throw up their unique challenges, and they require quite a lot of skill of the microbiologist to help us as a clinician in choosing the right antibiotic. I'm not a microbiologist, so I'm not may not do good justice about explaining each and every culture report. I'm not even a clinical pharmacist, because I think a pharmacist is required to dose correctly, particularly polymyxin B and colistin. And with regards to cost also, I'm not a financial expert also, because I think these drugs are getting costlier and costlier, and treatment is getting so expensive. I am just a physician who tries to help patients with infections. So we are running a little short of time, so I'll try to discuss 3 issues: diagnostics, therapeutics, and prevention. And I'll try to finish up within 30 minutes. So coming to case, I am practicing in an oncology center, so my cases will be oncology cases. A 32-year-old gentleman, previously healthy, who had fever for 2 days, then subsided on its own, then subsequently developed extreme weakness, which led to the diagnosis of AML, gets admitted to our center and gets started on induction chemotherapy, that is 7-3 or cytarabine daunorubicin, and is been given tablet prosaconazole as a prophylaxis for the mold prophylaxis. So day plus 10 of the starting chemotherapy, that is almost 12-13 days into admission, he develops high-grade fever with chills, no major localization on history and examination. His TLC is down 140. Blood cultures has been sent. Cefoperazone sulbactam, that is the first line of antibiotic which we initiate. And the next day, the oncologists feel that the patient is not improving. He's still having fever. They escalate to meropenem. Day plus 12, that is 48 hours of sending the blood cultures. His fever is slightly better. Culture has grown E. coli, and this is a fairly sensitive E. coli, which is the culture report is shown in the photograph. Day plus 17. So 5 days into the meropenem therapy, he's become febrile. Now there is reappearance of fever. This is the fever chart which has been attached. He's literally febrile all day. His tachycardic, his BP is borderline. His examination wise is normal. He's got mucositis and probably some fissure at the perianal area. He's currently on meropenem. So I would just like to ask inputs from the panelist. Probably we can start with the intensivist, Dr. Omender Singh, if he can give us more options. What should we go ahead with? Should we take blood cultures, escalate to meropenem, teicoplanin, blood cultures, escalate to only polymyxin B, blood cultures, and escalate to ceftazine, avibactam plus estonam, or we do a serum galactomannan and add amphotericin B?
So, Doctor, I think Dr. Taneja is also here. And this which we have been trying to do is that who has the right or the credential to prescribe antibiotics. What happens when the patient comes to the ICU? He already comes with not only antibiotics, but multiple antibiotics in wrong doses, not following any PQPD principles. And that is why we see a scenario like this actually. So that is why we are trying to develop a form which is a risk stratification model. If the patient has got risk factors for ESBL, risk factors for MDR, risk factor for CRE, those risk stratifications are mandatory before you jump onto, say, meropenem. And I think if we have time, we will discuss some of the new guidelines which have come up, that how the cultures may not be the right way to use antibiotics.
Sir, would you like to answer which antibiotic to choose in this case if this is the current scenario which we have? We don't. 1 gram, 3.
Actually, starting itself was not appropriate. I think in any ICU in Delhi, at least NCR, cefoperazone sulbactam in a febrile neutropenic patient is not the right antibiotic. And after that, I think apart from blood cultures have to go from other sites also. You have to send from the anal swab and oral swab, and all those cultures have to go. All cultures should be sent in febrile neutropenia. And one has to consider gram-positive walls cover also here, and fungal also, because it's already responded to meropenem, this recurrence of fever. So one has to have a broader outlook here.
Yes, madam.
If it is an ESBL, there is no one dose of meropenem. If you see the recent IDSA guidelines for antimicrobial resistance, prescribing antibiotics, there is no one dose actually. The minimum dose is 2 grams. And you see and we have been thinking that how much we can use actually. And you see the meropenem verobactam combination which is coming out for MBL, the dose is 4 grams, 12 grams in a day. This underdosing of the antibiotics is the basic root cause for the antimicrobial resistance which we are facing. So when you say I use this, should I switch over to this? Before that, we need to think that can we optimize the PKPD? Can we relook at the antibiogram? Because what I have seen in there's lot of things behind the antibiogram. If we show some of the antibiograms, we can discuss that actually.
Yes, madam. Yes, madam. No, I mean, we have not done anything as of now. It just looked like there was an anal fissure, but more of it was mucositis. They can develop perianal abscess, which can cause all these things.
I would say that with anal fissure, Staphylococcus would be an important pathogen coming from the anus. So I would say go on to either vancomycin or teicoplanin and repeat the blood culture and the culture from the site of the anal fissure. At that stage, you may be able to isolate the bacteria which may have become resistant to the antibiotics chosen. So these are 2 steps that I think should be done.
Sir, in our hospital, I mean, from our hospital antibiogram, we rarely see febrile neutropenic patients coming with or getting Staph aureus infections. So I agree.
Perianal.
I agree with your point, but I'm just trying to say that that is not a priority pathogen in our hospital. Any other audience member maybe would like to add what would be the antibiotic of choice right now? Someone who is deteriorating on meropenem and having severe neutropenia is expected to have neutropenia for quite a long. Anyone? Yes. Okay. So we repeated the cultures, but we thought that the patient was not improving and probably would have been shifted to ICU. We added polymyxin B because we generally don't see that much of gram positives in our hospital. We don't stress too much unless and until there's an obvious focus. Like sir said, anything has grown from the anal swab. We didn't do that. We just added polymyxin B. And there was a marginal improvement in fever pattern. And the culture which was sent, repeat culture which was sent, has flagged the gram-negative bacilli. The information came from the microbiology lab. So I would like to ask Sir Chandvatal sir, any additional test from a microbiology point of view which we can do on this flagged blood culture bottle, which may help us in rationalizing antibiotics in a quicker way?
What I was wondering, are you really doubting that you do not have a gram-neg septicemia? Number one, if you have that in mind, PCT may give you some clue that yes, this patient is raging with a gram-neg septicemia or bacteremia as it is. The subsequent tests, as you think of, we also add in our hospital CRP, which though is a non-specific assay, and try and see the prognostic value of it. Is it increasing or not? So blood culture has given you a yield, and as microbiologists, blood cultures are very sacrosanct for us. If taken properly and if taken adequately, it should be dependent on for the therapy with its sensitivity.
So should we wait for the final blood culture report, or can we add on to any
You
test?
already said that you have an antibiogram for that. So whatever gram next you are having primarily the sensitivity pattern, even you have also isolated a gram neg on this patient. So E. coli, if that can give you some lead that this could be the same bug which has had a breakthrough with a different antibiogram, you could try and use that antibiogram.
Okay, thank you. Anyone, any other microbiology input from this at this point? Yes, ma'am.
Flat positive. A simple gram stain, sir, would.
No, gram stain has shown gram negative bacilli. I just want to know anything additional at this point. BCID. Okay. So, I mean, we don't have too much access to all these tests, but what we did was, as Sir was saying, that we followed our antibiogram, and most of our E. coli, at least 25% of E. coli is resistant to meropenem, so carbapenem. So we gave polymyxin B and we just did a wait and watch. So just to discuss and for the benefit of the audience, what are the mechanisms of resistance of, I'm just trying to say that what are the mechanisms of resistance? They can be non-enzymatic mechanism of resistance and enzymatic mechanisms of resistance. Some of these are picked up by the BCID panel and the CARBAR, which was spoken by Vikas and Neha madam. So coming to carbapenemase testing, we can do the test from the blood culture bottle itself or the broth, or from the bacterial colonies. As someone said, BCID2 panel, which basically is now available and picks up, identify a lot of bugs, including gram negatives, most of the common gram negatives which we see, and also tells us about the genetic mutations which can be present in those gram negatives. And there is something known as verigene, which, as far as I know, is not available in India. Then we can do the test from the bacterial colonies, which is CARBA, NP, MSIM or eSIM, and then CARBA 5 test, immunoassay test, or molecular test like expert CARBAR. And modified, I mean, just briefly discussing all these things. These are tests which take, this test MKIM takes a lot of time. It takes around 18 to 24 hours, and although it has very good sensitivity and specificity, but it has its limitations. CARBA NP is basically a phenotypic test. It gives the result rapidly, and but it does not differentiate between the class of carbapenems. You can just tell whether the carbapenem is present or absent. And then, as the photograph shows, it's a rapid test, lateral flow immunoassay, which can tell you which kind of an enzyme is present in the colony of the bacteria which has been isolated. In the molecular test, which is CARBAR, which is more frequently available in Delhi and other parts of the India, which is a qualitative test and gives a real-time PCR test for detection or differentiation of KPC, NDM, WIM, OXA48, and IMP in 48 minutes. And it's been approved from the culture plate colonies of the rectal swabs, not approved directly from the blood. So coming back to the case, 48 hours later, his final culture report showed Klebsiella pneumoniae, which was, as you can see, mostly resistant. I will read out. It was sensitive to chloramphenicol, sensitive to colistin with MIC of less than 0.5, sensitive to phosphomycin, but MIC was not given. Imipenem, it showed MIC of 2 with moderately sensitive report, and polymyxin B was sensitive. Rest all was resistant. And we did a CARBAR on this, which showed OXA48 and NDM detected. So this is his fever pattern, which is now started touching the baseline, but still febrile. And speaking to the oncologist, they say that the TLC will take another 4 or 5 days. Patient is febrile but stable. Apart from the mucositis, there is no clinical localization. We didn't do an MRI of the perianal area, and probably I thought that the source of infection was a gut translocation because of the mucositis itself, as generally it happens in febrile neutropenia and in AML patients. So with this culture report and this information of the molecular mechanism, I just want to get input from the panelists. How will you manage these patients? I mean, I can list out the options, but you can, whatever, if you have any input, sir.
I think meropenem was resistant.
Yes, sir, resistant.
And the polymyxin was sensitive.
Sensitive. Sir.
And the condition of the patient is
he is stable but still febrile.
Vitals are stable.
Vitals are stable but still febrile.
So is he improving or deteriorating?
Clinically, I feel he's improving in the sense that fever pattern, which was not touching the baseline, also now in the last 2 days it has started touching the baseline also.
So probably I think you can change if meropenem is resistant, and polymyxin plus phosphomycin might be a good option. Phosphomycin, you can have a higher dose, 16 grams per day, and polymyxin might.
Okay, sir.
Since we are getting a clinical response, better to maybe step up polymyxin to a continuous infusion rather than give it as a bolus, because your MIC is 0.5. So if you step up the serum concentration of polymyxin, you will get a better response. And I would, since the meropenem is resistant, I would take away meropenem at this stage and just stick to polymyxin to cover this person's E. coli. Klebsiella.
Monotherapy of polymyxin.
Monotherapy
with
of
infusion,
polymyxin in high dose and continuous infusion.
Okay. Sir, any input from you, sir?
Your molecular typing had also shown that it may have OXA48.
Yes.
With
and CARBA and NDM.
And NDM as it is. So you could have the avibactam combination. You could think of even that. So that could give a additional lead in case you didn't want to give the polymyxins.
Sir, put sir, if you have any.
But see, the ceftidine avibactam won't be effective against NDM.
With astronam, you see the combination of avibactam with astronam, that's how it works. The astronam will work in NDM when the avibactam is there.
Dr. Soman also, I discussed this with Dr. Soman also, but I read this IDAC new guidelines which were published in March. The recommendation is only for MBL. The recommendation is not for recommendation is for MBL mechanism, not for NDM, because we are using for CRE, we are using this combination of ceftidine avibactam 2.5 gram infusion over 8 hours, and with the same in the Y connector we are using 2 gram STNM, but that combination recommendation is only for MBL. I don't think the recommendation is for NDM.
Sir, MBL is a broader term than metallo-beta-lactamase. NDM is one of the enzymes of MBL.
One of the mechanisms of resistance, and it allows the astronam to work.
I just want to ask experts from the audience, would they switch, or just as sir said, he's clinically improving, so just monotherapy, or will keep the same? What would you do? Anyone? Sir? Parikshit, sir. Sir, anyway, you are, I think, audible in the hall. It's a small hall.
So one thing is, with carbapenem resistant Enterobacteriaceae, I would not use monotherapy. If you look at literature, the highest evidence exists for combination therapy for Enterobacteriaceae. If this would have been an Acinetobacter, then it would have been another case. The other thing is with monotherapy, again, at this point of time, we are not able to optimize the pharmacodynamics for most of our patients. We don't do colistin levels. We don't get accurate MICs. Most of the centers are dependent on, machine given MICs. So we are really not doing the broth microdilution manually. Even if we do, it is challenging. So definitely I wouldn't go for monotherapy with polymyxin. One option would be polymyxin plus something else, which would not be meropenem given the high MICs, or Zavicefta plus Astronam. But then again, with the caveat that we should do synergy testing. In the last 6 months, we have had 6 patients who have had an OXA 48 plus NDM like picture and who have failed, the synergy test. So either ways, we will have to optimize the micro aspect here, getting accurate colistin MICs or getting synergy testing, whichever way you go about.
So just wanted to ask, how many of you have the facility of doing synergy testing for ceftazine avibactam, and only 1, 2? Sir, you are on the same institute.
Yeah, we are on the same. So we recently started doing synergy testing for ceftazidime avibactam plus Astronam, and the guidelines for that have been published in the ICMR paper, which Nitin happened to be the lead author on that. What we have noticed, and also from the previous literature, is that when you are using ceftazidime avibactam plus Astronam combination, you need to keep in mind few things. One is that it would work only against Klebsiella, and the chances of that working out is only around 80%, because the sensitivities earlier for that combination for NDM plus OXA were around 93% to start off with. They have actually gradually dropped over time, and it has actually come down to 80%. But if you look at E. coli, the same cannot be said, because there is another mutation which is known as PBP3 insert. Because of that mutation, the synergy testing, the combination synergy actually drops down to only 30%. So it's very important to know which organism among the Enterobacteriaceae you are dealing with, and what is the synergy profile of that isolate. So it is very important to start synergy. We should not rely on the genotypic test alone to guide our therapy. And another point which I want to make for ceftazidime avibactam plus Astronam combination is that it should never be empirical. It should always be directed. We should have the genotypic pattern. We should have the phenotypic synergy testing available. Then only we should use it. And I would use it only for Klebsiella, not for any other Enterobacteriaceae as of now. It does not work against Acinetobacter. It does not work against Pseudomonas. The chances of it working for E. coli is only 30%.
So you would not use it?
It can be used. Among the Enterobacter, as Dr. Vikas has mentioned, definitely no activity against Acinetobacter zero, but in my clinical practice, even for Enterobacter, it has been very good. It has given good results.
So monotherapy with colistin or polymyxin, we know that it's a poor antibiotic. And even CLSI has withdrawn the guidelines for its sensitivity patterns. So a monotherapy with polymyxin in a patient like this, breakthrough infections is a likelihood.
Totally agree, sir.
Dr. Deswal, also with this combination, this is like a game playing sort of a thing. We are trying to make combinations. Are these combinations valid for septic shock patients or they are valid just for stable patients? Because I understand the word which I learned from Dr. Rivermore, which is also our visiting faculty, the inoculum effect, which says that, and is old, we learned from you people only, the inoculum effect, and these kind of say beta lactamase inhibitors, they say should be avoided. And if you see again the same guidelines published by the IDSA, they say even if it is sensitive and it is ESBL, please do not use beta lactamase combinations. So we need to see what population you are treating actually. I know, with all respect to ID specialists, because you give opinion, then go away, and then we handle the later scenarios. Because we add on one more vasopressors, the bacteria gets negative, but the patient doesn't get better. So most of the time we see those scenarios.
So the problem with polymyxins is that the pharmacokinetics are not linear, and we do not have good correlates of drug levels with the outcomes. So so based on those two things, the pharmacokinetic profile and the no relation of MIC values, despite being in susceptible range with the outcomes, the CLSI in 2020 actually said that we cannot report it as susceptible if the MIC is less than 2. They changed it to intermediate because of that reason itself. Whereas if you compare that with ceftazidime, avibactam, or even astronam combination, depending on the situation, the pharmacokinetics for that are pretty well understood. And there are studies which have actually compared, although the data is not very good, there is some retrospective data, there is some observational data which is available, which shows that when you are using ceftazidime, avibactam plus minus astronam for either NDM plus oxa or oxa alone, that actually performs better than polymyxin. Parikshit, you want to add?
No, sorry. So if you look at polymyxin therapy, if you look at the AUC MIC ratios, then let's say we do even achieve good levels. Let's say we achieve good levels with polymyxin, then you would be expected to achieve AUCs of around 50. Now, if you divide that by MICs for most of our isolates, our AUC MIC ratios are barely around 25 to 30. Now, they are not even enough to establish a 2-log kill. So, in vitro also there is a lot of evidence for poor efficacy for polymyxins. And now add to this that 50% of the patients who have GFRs of more than 80 are unlikely to achieve levels of 2. So most of the times we are achieving levels of less than 2, which means we are achieving AUCs of less than 50. And if you look at the MICs in our setup, if you look at the MIC data, at least from UK, then most of the MICs are closer to 1 to 2 than to 0.25, 0.5. So our AUC MICs would be really, really poor in this setup. The inoculum effect that you talked about for ESBLs, that has been well described for tazobactam in the face of ESBLs. But this is a different bug altogether. I mean, these are carbapenemases. So if you look at avibactam literature and if you look at the IC50s for avibactam versus relibactam, vaborbactam, then definitely there is a good amount of in vitro data for this. So I wouldn't be worried about inoculum effect here. I would be much more worried about pharmacodynamic failure of polymyxin.
So that's why, I told that we need a clinical pharmacist to discuss all these things. Madam, you want to add anything?
It's just
Otherwise,
that,
I'll move on.
yeah, definitely with all of this, but here there has been a clinical response as well, partially. My first concern whenever we have something like this would be, is there any focus which we are not ruling? Clinical response. So in this patient, the options could be that we have polymyxin with imipenem. The other option, obviously, we have to, as mentioned, that we need to have susceptibility, but a lot of times we can't wait for the susceptibility to come when a patient is very sick, like a critically ill patient who's having hypertension or a febrile neutropenic patient. So there we have to obviously go empirically, and currently, obviously, ceftazidime, avibactam plus astronam could be another option with addition of probably metrogyl if we are dealing with intra-abdominal infections.
Perianal infections. So moving on with the case, yes.
We do have this 90-60 rule in microbiology. I think Dr. Gupta agree with me. So even if he reports some antibiotic to be resistant, it may work in vivo. So maybe since the patient is responding to the combination, maybe we can continue with this combination poly B with the meropenem, and it does work later on itself.
With imipenem, would if you have to see Miro anyways, it's resistant.
And the infusion, not the bolus.
But I think is that what sir said, no, that we write an order and then suddenly patient crashes, then it's something, then we are not held responsible that something like that happens. That we also
Learn one thing, that even if it is working, at least optimize the PKPD.
definitely.
Because if you see the guidelines also, they say they are divided into two groups. One is the patient who is stable and the patient who is in the ICU. In ICU, they say give prolonged infusion. Any antibiotic you see imipenem, they say give it 30 minutes. In ICU, it was 2 hours, and now the new guidelines say you can give it up to 3 hours. Optimization of PKD, I don't think we'll need a clinical pharmacist for that. Actually.
So I will move on. These are the latest recommendations. I'll skip these slides. Everybody knows, and this is the synergy test for the benefit of the audience if someone is not aware. Basically, placing two strips either simultaneously or one over the other. You can obviously go through the guidelines for better detail. So we actually we just did what Dr. Neha madam was saying. We just gave high dose imipenem 1 gram Q8 hourly in a prolonged infusion of around 2 hours and continued polymyxin B. We didn't go for ceftazine, avibactam and estrogen combination in this case. What I just wanted to discuss was these are guidelines has been written, but they need to be taken with a pinch of salt considering the infrastructure which we have. Does the microbiology lab support us with the synergy test? Does they have the molecular mechanisms to tell us not every microbiology lab is well equipped as maybe some other labs? So in our patient, synergy test was negative. I'm not sure why synergy test was negative. Maybe some other mechanisms of resistance are taking place. And we used imipenem plus polymyxin B and waited for the neutrophil recovery, and slowly his neutrophil counts fell down and neutrophil count improved. So both molecular advances and traditional microbiology methods are required to help us help physicians manage patients with CRE. I think we have a talk tomorrow on conventional microbiologic methods, which may help us enlightening more. And caution is required when we use just pure molecular methods in making clinical decisions. Traditional methods showing in vitro susceptibility is actually quite important. I think in interest of time, I have to stop because I had few more cases, but I have to stop. Sir. Thank you so much, sir. Sir, any reference?
1 gram 8 hourly.
Sir, reference is, I think what I know, sir, standard dose is 1 gram 8 hourly.
Because the recent guidelines suggested that the maximum dose of imipenem can be increased up to.
So you were asking about imipenem, sir. I thought meropenem. So imipenem in
It was 500 8 hourly. The recent guidelines said you can use 500 milligram infusion. Two changes in the imipenem guidelines. One is the duration, which was 2 hours, has been increased to 3 hours. And 500 milligram 8 hourly has been increased to 500 milligram 6 hours.
So those guidelines are for the isolates where imipenem is sensitive, but when you are using it in a combination therapy where.
Any reference for 1 gram?
Sir, I can give you references, but I mean right now I don't have the reference.
Children, we use up to 120 milligrams of meropenem per kilogram.
Yes.
So if it's an adult with 60 kilo body weight, you can easily go up much more than 1 gram.
So for meropenem, we generally go up to 6 grams in a day. I mean, 6 grams.
We use 120 per kilogram.
Yeah. And generally we restrict those either when we are treating it for giving for meningeal doses, or we have been giving it as a part of the combination therapy where the susceptibility shows that it is moderately sensitive, borderline MS.
Just like to make one point now, talking about meropenem dose is 6 gram per day. So, in sepsis where you get a lot of fluids and all, and body weight may be more, the recent guidelines are coming up for therapeutic drug monitoring. My ID colleagues will be knowing much more than this. But the way forward is probably going to be therapeutic drug monitoring, and therefore even 6 grams is insufficient in some cases. And with TDM, they are giving even up to 8 grams, 10 grams, 12 grams, and each dose has to be individualized. I don't know when that will come, but that is the way forward. A lot of patients have renal failure on dialysis, so the dosing is very, there are no real guidelines for dosing in these patients also. So the way forward is therapeutic drug monitoring to optimize PKPD.
Thank you, sir. Thank you.
So thank you so much. We had a very interactive session with Dr. Nitin Bansal and our expert panelists. And we move on to the next session, which is on gram-positive GPC in the blood, how to interpret. And for this, I request Colonel Kiran and Dr. Indu Kulshrestha to please moderate the session. Dr. Indu Kulshrestha is a senior consultant, senior physician in St. Stephen's Hospital. And Colonel Kiran, as we know, has just presented a wonderful case on rabies. They are going to invite the speaker, which is Dr. Jatin Ahuja. He is a senior consultant in infectious diseases in Apollo Hospital.
Dr. Jatin is a close friend of mine and an ID physician, has done his training from AIMS, BM infectious disease from AIMS, and he's presently working with Apollo and also has his own clinic, Penicillin Clinic. Very active on Twitter and very active on LinkedIn. I could see him. In fact, lot many things about to tell, but anyway, I request Dr. Jatin to go ahead with his presentation.
Yeah, thank you, Dr. Kiran, and good afternoon, and warm regards to everyone. And I also like to thank the CIDS for organizing the first Delhi chapter over here. And with this, you have already listened to parasitic infections by Dr. Vikas, the complex rabies by Dr. Kiran, and the GNB by, again, Dr. Nitin. So I move on to the very basic microbiology and a few clinical aspects, that is the gram-positive cocci, that is the GPC. It is a toothache for every physician who deals with day in and day out in the ICU settings, especially with immunocompromised populations. So things in my mind after getting the provisional reports of GPC, whenever the microbiologist called to us that yes, they grew GPC after getting a signal from the, that is the blood broth. So it's a true colonizer or it's a true infection. To evaluate for a gram-positive bacterial infection is mandatory. So what kind of dealing we are, whether it's a true or it's a colonizer. And then ID and AST. Identification is a must. And then followed by the antibiotic susceptibility testing. And the last is the treatment part. Whether we need to treat, if we have to treat, it should be a true infection, not the colonizer. So why early ID or identification is a must? So reduction in the use of a bloodstream antibiotics and broad spectrum antibiotics, increase rate of the nosocomial infections, which can be reduced by optimizing our antibiotics. And the last is the target therapy based on the AST, which we get after the microbiology who tells us that yes, but it will take certain time. But gram-positive cocci, it is the first thing which can be signaled very early after from the blood culture broth within 24 hours, I would say. The patient entering in the ER with sepsis, the patient is already undergoing the chemotherapy. Patient has the PICC line in situ and is coming in the midnight with the in the emergency room, ER room, and the resident or physician on call with the disinfectant care, he took the paired samples from the patient. So how much blood to be taken? As of now, it's 8 to 10 ml blood is recommended, and the protocol has been followed by the treating or resident doctor. So overfilling could also cause inaccurate estimations. However, again, the less than the mark, less than 8 ml, again can cause the false negative results. So as soon as the patient enters, it's now a, I would say the Delhi current scenario. The patient comes to the emergency room, patient is immunocompromised, start with the meropenem and the teicoplanin. That is the first drug of choice which we see in our emergency room settings. So, but being a clinician, being a physician, what could be the source of the sepsis? If the patient we are suspecting that the SOFA score is 2 or more than 2, a quick SOFA score, I would say. So we should be saying that it's a sepsis. But what are the source of the sepsis? So there are the 5 organs, I would say, which can be the potential source of the pathogen. It could be skin, it could be CNS, chest, and abdomen, and the last is the genitourinary. So my resident took the blood cultures, and that is the automated continuous blood cultures. These days are available everywhere. And after few hours of the in incubation, we got the signal, and that signal turns the green part into the yellow part, which shows that something is there, something is cooking into the blood culture broth. So what is that? First, we took the gram staining, and that turned out to be a gram positive cocci, that is the GPC. Now the story starts. So this is the traditional test, GPC and the bench test, which we have studied in our second prof during our microbiology time. It's a broad classification. We know that we are dealing with cocci. So cocci is either the chain, paired, or it's a clusters. So we know that cluster. I will go in the further slide. It's a very busy slide just for the highlighting over here. So gram positive cocci means clusters. That means staphylococcus or the micrococcus. Why they are clusters? It's a very simple microbiological phenomenon. They divide in two axes, x-axis and the y-axis. That is why they take a form of tetrad or cluster. Cocci chains, they divide only in the single axis. That is why they are streptococcus or the enterococcus species. And the last is the cocci. It is a pair, streptococcus pneumoniae. So series of steps taken whenever microbiologist call, and doctor on call gets it that something GPC is cooking up. And what we do, we open up the up-to-date to look for whether we need to treat it and what kind of treatment we require based on the clinical scenario. So this is a 30-year-old gentleman on mechanical ventilator after the diagnosis of ARDS, and he is COVID RT-PCR positive, started mounting fever, and paired blood samples were sent. That is central line as well as the peripheral line. Gram staining from the blood cultures brought showing the gram positive cocci, that is from the CL, central line. What is the most likely organism and its significance? So we have three scenarios. So if the GPC in blood is growing both in the central line as well as peripheral line, or it could be negative also, positive, negative, would you consider it as a true infection? Anyone from the audience? So patient is having the CL and PL both in C2, central line and peripheral line blood has been taken, and CL is showing the GPC and peripheral line is negative. Would you consider it for the targeting with the therapy? Though patient is having the sign and symptoms suggestive of the sepsis, can GPC contributing to this? So as for now, they don't fall under the category of the KFC. Yes, that could be other sources also. That could be COTI also. Pardon, sir?
As a gram positives,
yes,
are very uncommon for ventilator associated pneumonia.
Yes, sir. But here we are talking about the in the blood GPC are growing up. The GPC we are showing over here in the blood, central line and the peripheral line. The positive is there and the negative from the peripheral line. So it cannot be categorized under the definition of the catheter-related bloodstream infection. And if we consider both are positive, then only we can say it is a catheter-related bloodstream infection. Though it has again a star mark, there are further terms and conditions. But if CL is negative, peripheral line is showing positive, can it be a CRBSI? We cannot say exactly it's a CRBSI because it depends upon what kind of pathogen we are isolating. If it is a skin commensal, we can straight away ignore it. So for saying it's a CRBSI, we have to be typical criteria are same organism grows from the peripheral blood culture and the catheter tip, but requires catheter removal. One and foremost requirement. Same organism grows more than 2 hours earlier from the line culture compared to the peripheral blood culture. That is again the second criteria should be fulfilled. Or same organism grows with the 3 times higher colony count from the cultures compared to the peripheral blood cultures. So if either of the 3 are fulfilled, we can say that our second part was the CRBSI. Sorry. So what are the differential for GPCs in blood causing the CRBSI? As I already mentioned earlier, it's a staph species, whether it's a staph aureus or cons. It could be streptococcus species. It could be enterococcus. But last should not be ignored. It can be anaerobes also. Sometimes we're putting a central line in our IJV, and there can be peptostreptococcus and identifying on the further blood culture broth. So ID and the AST both go hand in hand. First is the identification, whether it's a GPC or not, and then from the various techniques, whether it can be molecular techniques or it could be Malditoff. We have to go for the AST testing also to further guide our antibiotic therapy. So these days, this therapy has come up recently directly from the blood culture broth. We are going for the AST, but it's not been standardized. But there are certain labs who are doing these days directly from the broth and going for the antibiotic susceptibility testing. Though it's not been standardized, though Vitek can be done after taking the subculture, and from subculture directly undergoing further for the identification as well as the AST. This is the second case scenario. Elderly wheelchair-bound lady had a history of recurrent urinary tract infections. She presented with new onset of fever, chills, and confusion. Blood cultures were drawn, and gram stain showed again gram-positive cocci. Again this time, in urine culture, GPC were reported. ID is awaited, and urine pus cultures were fulfilled. So it's a urosepsis, and that too with the gram-positive cocci. So what could be the pathogens responsible for in this case? Enterococcus, one possibility. Can be something else. So these are three species which can commonly responsible for the uropathogens causing the gram-positive cocci bacteremia, Staph, Enterococcus, and the Streptococcus. However, Staph species, especially in the young ladies, those who are not catheterized, Staph saprophyticus or Staph lugdunensis, they are commonly seen. But in the elderly, as I mentioned, it's the Enterococcus quite commonly seen, especially in those who are immunocompromised and indwelling long-term catheters are there. Another case, 51-year-old male, a case of periampullary carcinoma and on palliative treatment. Underwent ERCP and CBD stent placement 2 weeks back. He presented with new onset of fever, chills, pain abdomen, and the confusion, satisfying the criteria of sepsis. Blood cultures were drawn, and gram stain showed again the GPC. What could be the most likely organism over here? GPC in a acute biliary cholangitis. Enterococcus. So here we have to highlight that not only the Enterococcus faecalis or faecium, there could be non-faecalis, non-faecium species can also be responsible for this bacteremia, like Cassili or the Gallinarium. The idea to highlight over here is both are moderate to high resistant in terms of the vancomycins. So if we are not identifying the further subspecies, only the Enterococcus is there, we can switch our therapy to the non-vancomycin space therapy like the linezolid or the daptomycin. Another case, a 17-year-old male presented with the microscopic hematuria and the proteinuria and a fever 5 months after having the TERP. The patient was concerned that he was not getting better and he self-referred to a physician. He had continuing fever, weight loss, and the malaise. The physician detected a mitral pansystolic murmur. Paired blood cultures were drawn and gram stain showed gram-positive cocci. Again, what is the most likely organism? It could be again it could be Streptococcus species or Enterococcus, and what could be else? So here in this case, we observe signals in the blood culture, but gram stain appears similar to the Streptococcus viridans. Sheep blood agar also did not show any growth, so it could be a culture negative infective endocarditis. However, chocolate agar or a kind of a selective medium grew growth. Similarly to that, just like a Neisseria, but it is a GPC. Any guesses for that?
Gentleman had already received antibiotics. That's why it was a culture negative.
It one possibility, yes, sir. He might have started on the antibiotics earlier outside, or might be taking over the prescription or OTC. But chocolate agar grew growth. However, stacking SBA with staphylococcal streak. What makes the staphylococcal streak to grow this bacteria? However, on a simple plain sheep blood agar, the bacteria was unable to grow. Yes, absolutely yes. But sir, again, it's a gram negative.
That's a coccobacillus.
But gram negative, sir. It's a gram negative bacilli. Pardon? Abiotrophia, yeah. So it's a nutritional variant Streptococcus. It's a GPC, and clinical presentation of endocarditis is similar to viridans group Streptococcus, And abiotrophia and the granular catala, they are the NVS category. And blood culture often requires supplementation with the vitamin B6, that is pyridoxal phosphate or pyridoxal HCl, along with the cysteine. So when we have this Staphylococcus streak on the sheep blood agar, in the beta hemolysis area, there are small pinpoint colonies which can hint us that it is not something Streptococcus viridans, it is the nutritional variant Streptococci. Quite common, though we are not able to isolate directly from the sheep blood agar after subculturing, but in a further selective medium, we can detect the abiotrophia. Less than 5% of the cases of culture infective endocarditis are responsible for the abiotrophia and the granular catala. The common sources are the oral cavity and the abdominal infections. This is just a simple same thing. So true bacteremia or contamination, blood samples collection should be taken in a stringent way after proper disinfection. 2 or 3 set of blood cultures are sufficient. Clinical criteria must be fulfilled in every patient before we say it's a GPC and they are significant. Laboratory criteria, again, it should be fulfilled. Pure culture, single bacterial strain cultivated in culture, though it should not be a skin flora. If we're talking about single bacterial strain, it should not be a skin flora. Mixed culture, growth of 2 or more than other pathogens in 1 or more sets of blood cultures. And laboratory confirmed blood infections, 1 positive blood culture with a recognized pathogen, and skin organism more than 2 blood culture positive should be there.
Dr. Jatin, can you just
Yeah, just so my take home message is gram staining finding must be correlated with the culture results. Very important. Nowadays, after directly with the signal positivity, we go for the AST and the identification. No, we should stick to our basic rule, that is the gram staining. Second thing, a gram staining plus multiple bacterial species and only 1 or 2 aerobic species isolated in the culture hint towards the presence of anaerobes, that is Streptococcus and other anaerobic gram-positive cocci. If gram staining is positive and the cultures are negative, as Sir has mentioned, it could be a false negative because of prior antibiotics, it could be presence of anaerobes or any Fastidium organism that I have already mentioned, that is a nutritional variant Streptococci. With this, thank you very much, and over to you, sir.
I have one question to you, Dr.
Yes, sir.
Jatin. Man with prosthetic valve, suspicious vegetation. You sent 2 sets of blood culture or 3 sets of blood culture, and only 1 bottle grew corns. What's your take?
So first of all, I would like to take into the history into the consideration whether it's a early prosthetic valve or it's a late prosthetic valve. One thing. Second thing is that it's a growing corns. So one spade has come positive.
Only one bottle has flat positive.
Or 1 bottle fat positive. From which
one?
Not from the central line, only the peripheral.
He just come from.
Okay, sir.
Just come.
Okay.
There's a suspicion. There's an infective endocarditis. Not very clear, but they just got 1 bottle. See, it's a very common scenario.
Absolutely, yes, sir.
Okay.
So if we are seeing that, so now here comes the role of a clinical scenario. If the patient is again having the.
I'll again tell you, most of CTV surgeons are unwilling to stop teicoplanin, and they hold teicoplanin as if it's a girlfriend. I'm telling you the truth. Okay. So it's so difficult. Every day I have to say, doctor, you've not given teicoplanin. I have a graph there. How can you not give MRSA cover?
Yeah, I agree with that completely. But in our unpublished experience of, I think, close to 140 cases of endocarditis, and we saw quite a number of prostatic valve infective endocarditis as well. The most common cause for prostatic valve endocarditis is still VGS rather than the GNB or even
absolutely, yes.
cons. And single positive blood culture is likely a contaminant.
But sir, but ma'am, if it's a clinical criteria is suspecting. Sir, in this I would like, ma'am, in this I'd like to mention that what are the other blood cultures? Are they been taken in an adequate amount? If that is showing the growth, it might be the adequate sample must be have taken, and if it is matching with the clinical criteria, I would say it should be hit. If it is matching with the clinical criteria, if it is not, then it should be taken as a colonizer or commensal, whatever it is.
Correct.
Thank you. Thank you, Dr.
Thank you very much.
So, in the interest of time, now we will break for the tea, and this is going to be just for 10 minutes. And we are going to reassemble here, requesting all of you to come back in 10 minutes, please.
And to deliver the talk and discuss the cases, I have Dr. Neha Gupta. She is one of the pioneers of ID in northern part of India and has been conducting a lot of conferences and giving a lot of talks. I welcome you, ma'am.
So we begin?
Will you give us the chance to introduce you, Neha?
Yeah, please, please.
She's so excited to start. So as we know, this is, this ID conference is a baby of Neha here, and she is collecting all people. So there, she doesn't need any introduction, but she is, I think, currently infectious disease specialist at the Fortis Hospital, Gurgaon. And she was the ex-consultant ID, Hinduja and the Medanta, the Medicity. She got the, in 2016, Healthcare Award from the Director General Health Services, Government of India. She is the executive member CIDS since 2012. And she has her own clinic as well. She is working with the Fortis Hospital, Gurgaon.
Thank you so much, Dr. Ruby. And thank you so much for all of you to come here. I think we are lucky to have this physical meeting during the ceasefire of COVID-19. And I hope this continues as well. So I'm Dr. Neha Gupta, Senior Infectious Diseases Physician and founder of the NG-SWAST, which is the Infectious Diseases Clinic in Gurgaon. And I'm also attached to FMRI at the moment. So isn't ID interesting? Yes, I think it is very, very interesting. So we are going to discuss interesting cases in infectious diseases and HIV. And can we have just a show of hands to see how many of us are postgraduates here? Dr. Tanuja. Okay, that reminds me. Yeah, sure. Currently doing post-graduation, but this actually goes with the quote which my mentor, Dr. Rajeev Soman, would say, that we are always trying to be better clinicians throughout our lives. So, so I'll begin with this first case. I'm going to have a couple of cases and I'm trying to complete them within the time. Right now it's 5:45, so hopefully we should be finishing it in another 20-25 minutes in the interest of time here. So this is a 53-year-old gentleman with no comorbidities. He had a frequent travel to Goa and his last visit was in August during the heavy rainfalls. And this is one of the very old cases which I had seen close to a decade back, but it has a very clinical significance with collaboration of all the investigations and their interpretation. So in 2012, he presented with this acute febrile illness and there was also thrombocytopenia. He was diagnosed to have P. vivax malaria, which was based on the PS for MP, and he was treated with artesunate. He also received ceftriaxone as any fever would get it. He had not taken primaquine. His wife had also developed malaria at that point. Now, a few days later, after this acute febrile illness, this patient develops fever again. He has a left-sided pleuritic chest pain with pleural effusion. Also, arthralgia, hepatomegaly, there is LFT alteration going up to definitely very significant, more than 5 times the upper limit of normal. Then he went somewhere else where there were lymph nodes on physical examination. The biopsy was not done. And at that point, an empirical anti-TB drug was initiated. He had somehow some good clinical response. There was resolution of fever as well as weight gain. Now, a month later, this patient presented with high-grade fever again, along with arthralgia. There were bilateral knee as well as small finger joints which were also involved. So that's when he was advised admission. Anti-TB drugs were stopped by the clinician because he was having
he was febrile on the anti-TB drugs, and on examination there was bilateral axillary lymph nodes as well as arthritis. There was a progressively increasing WBC, as we can see here. It had gone up to 14,000. The platelets were normal. There was an X-ray which showed that the left-sided pleural effusion which was there had kind of resolved, but there was some fibrotic scarring which was visible. The blood cultures were low growth. He was extensively again evaluated even for endocarditis. Echo was normal. Wheel Felix as well as scrub typhus ELISA was done, which was positive and very strongly positive as well. The PET CT showed lymph nodes which were going in favor of some infective etiology. Now, this patient, based on all these investigations, was treated with azithromycin. He was later on shifted to tigecycline. Also, because the Wheel Felix was positive and the scrub typhus ELISA was positive, he was added on doxycycline. There was a decline in the fever, but there was no dramatic response as seen here. As we can see, you have the tigecycline, doxy, but still the patient is raging high fever and the arthralgia is persistent. So the next investigations reveal that he has a very high elevated ESR, ANA, anti-DS DNA, ANCA, all of them have also been done, which were negative and normal. This patient during the hospital admission now develops a right-sided pleural effusion with fibrotic strands, and this was an exudative pleural effusion with a lymphocytic predominance. A few mesothelin cells were also seen. The ADA was just borderline elevated of 24. Now with this, which of the following is most likely? Do you think this is melioidosis, scrub typhus, tuberculosis? Is it something else like a reactive arthritis, undifferentiated connective tissue, or none of the above? So before we go on to our experts, anyone from the audience, what do you think it is? What about melioidosis? So this patient is an elderly patient who has gone and traveled. He has gone outside and he has traveled as well. So to Goa and during the heavy rainfall as well. So there are certain points. Ankita, you want to say anything regarding melioidosis? What are the points in favor and probably the points against it?
One point is fever is there, long standing despite a lot of antibiotics not responding. And there's some problem. Please, I'll be. Thank you. So one thing is there is a fever that is not responding to all the antibiotics. All other tests are coming negative. Despite being on doxycycline, azithromycin, scrub typhus possibility is low because usually it responds within 48 hours if the proper treatment is initiated. So melioidosis with the travel history again, multiple sites involvement, so it becomes a strong possible DD. Blood culture sometimes give a good result with melioidosis.
Correct. So this patient definitely has a risk factors there, but in a patient who is having such a high fever, the blood cultures were still negative. So usually we will have a blood culture positive there. And melioidosis can present with consolidation. Here this patient is having only pleural effusion, X-ray showing only pleural effusion. Otherwise consolidation is also possible. So these are the points against it. Now, what about the scrub typhus? As you mentioned rightly, this patient is having fever, arthritis, pleural effusion. So there are some signs of serositis here. But if you look at it, also this patient has a Wheel Felix positive, Wheel Felix and a scrub typhus ELISA. But remember that these are non-specific tests. And in fact, even the package insert of these tests mentions that scrub typhus ELISA can be falsely positive in patients who have got pulmonary TB, malaria, enteric, VGS bacteremia. So any patient who's having fever can have these positive results. And it will all depend upon our pre-test probability. We need to jump and treat the positive. In this patient, as Dr. Ankita rightly mentioned, that there is a dramatic response to doxycycline, which was not seen in this patient. So the scrub typhus or rickettsiosis is very unlikely. Now, what about tuberculosis? So there are certain points like patient was having PO, which was again, there was an initial response to anti-TB drugs as well. There is a pleural effusion which has happened. But if you look at it, the patient had developed fever again on anti-TB drugs. The pleural fluid was not showing enough ADA. And also if you remember, the pleural fluid was showing few mesothelial cells. In case of tubercular pleural effusion, usually the mesothelial cells are absent. That is again one of the diagnostic clues also. And of course, the lymph node biopsy which was done, which was reactive. Now, there are certain other differentials which we also consider like a reactive arthritis. So definitely reactive arthritis points in favor could be that it can happen 2 to 3 weeks later after an infectious episode, but points against a very high fever and a long duration of illness. And there are certain other points against the undifferentiated connective tissue disorders, like the other serology which was performed, which was negative. The other differential in a patient with PO is always lymphoma, but here again the PET-CT and the lymph node biopsy was not suggestive of this. So the other possibility which we have to always consider as infectious diseases physicians are whether it's an infective cause or it's a non-infective etiology. So non-infective etiology like a adult onset Still's disease in this patient becomes very, very possibility. It is one of the rare inflammatory conditions, and it is basically a diagnosis of exclusion. Day fever, which is going up to 102 for a week or longer. Fever usually peaks in the late afternoon or early evening, so may initially mimic like tuberculosis or maybe like a lymphoproliferative disorder. But in between, the patient is absolutely, the temperature can also come back to normal. And there are other signs and symptoms which give us the clue: swollen joints, salmon pink rash, sore throat, swollen lymph nodes, hepatosplenomegaly, as well as inflammation of the lining of the heart and the lungs, which is effusion. And this is a test which definitely requires a diagnostic interpretation. In fact, I recently had a patient who was admitted for close to 1 month in another hospital and received all the broad spectrum antibiotics, and it turned out to be a case of adult onset Still's disease, which responded to prednisolone. So here in this patient, the investigations showed that he had leukocytosis, platelets were high, and of course a very high serum ferritin. The other investigative parameters were all negative, and the patient responded. This is one of the cases of infective etiology which we must consider, and he responded well. Now, yeah.
This patient had a Vivax positive malaria in Goa. Why couldn't this be another malaria based on the findings that you are giving? There was fever, hectic swinging temperatures. I don't know if there were chills or rigors, but falciparum is known to produce third spacing. So pleural effusions can be part of third spacing. And there was also arthralgias or arthritis.
Yes, arthralgia.
Arthralgia, arthritis.
So he had arthralgia predominantly. One or the two few of the joints also had swollen, so they were arthritis.
You can in malaria even get lymphadenopathy, and so all the findings. One of the differential diagnosis could be malaria.
Correct, but I think the yeah.
What the patient
Yes.
said, no problem.
Yes.
I'm just saying
Yes.
for discussion's sake.
The peripheral smear, yeah. I think ACE level must have been done anyways, it must have been done. Probably I didn't put it here because that was, I thought of putting only 5 options, so that's why. But ACE level definitely was done, and this was fitting. Sarcoidosis will not have such a high ferritin also. But, and also there was reactive lymphadenopathy, like the biopsy was also not granulomatous, it was reactive. Yeah, point taken. Definitely these are the various non-infective etiologies which we must consider. Definitely. Now we move on to another, any other comments from the audience? So we move on to the next case, which is patient who is a 47-year-old farmer, and in 2008 he had presented to us with involuntary movements in the right upper limb which extended to the left upper limb, and he had these chorioathenoid movements which developed over a period of 18 months. There were changes which are seen in the speech cognitive decline. MSSE score was 21/30, so he had a cognitive decline also. There was a significant weight loss which was observed. There was a past history of VZV twice. And in 2006, he had a right-sided hemiparesis, which was of sudden onset. So here, this is the MRI of this patient, which shows that there is prominence of the thalamic, there is hyperintensities which are noticed here, and there is a gliosis hyperintensity which is noticed on the left frontoparietal region. So anything else which you think is very striking in this MRI brain of this patient? Anything else? I heard it from the audience. Somebody said hydrocephalus. Yeah. So this left parietal, yes, absolutely. This is a history of old infarct. So that's why it's there. Plus hydrocephalus, it looks like, but there is cerebral volume loss. There is cerebral atrophy. So with this past history of VZV and an MRI chorioathenoid movements and MRI brain which is showing these cerebral volume or cerebral atrophy, what do you think this patient has? Yes, of course. Yes, this is a patient who has HIV-1, and he was also co-infected with hepatitis B. His CD4 count was 371 with a viral load of 3,830. His anti-toxo IgG was positive. Whenever we have a patient who has come with HIV, we have to do baseline evaluation where we do VTRL-TPHA, which is negative. Chest X-ray, ultrasound were all normal as well. So luckily, we had this opportunity to present this case or publish this as a movement disorder, which was one of the first cases which I had seen were presented with of a patient who is HIV positive and presented with these chorioathenoid movements in 2009. So HIV-associated neurological disorder, in fact, it persists in 30 to 50% of people who are living with HIV, and it causes a behavioral, cognitive, as well as motor deficits, even when the ART keeps the virus under control. Now, my question is, what is true in this patient? HIV directly affects the neurons. Activated brain macrophages and microglia release products which attribute to the cerebral volume loss, which is very prominent in most of the patients who are living with HIV. Now, we give antiretroviral therapy with high CP score. The ART with high CP score increases neurotoxicity and should be avoided. Fourth, all of the above. So what do you think is true? Comments from the audience, please. All of the above? So there's a catch here. Who said two? Yeah, brilliant, brilliant, brilliant. So we have, yes, HIV indirectly affects the neurons. It is very interesting in HIV that HIV affects most of the organs of the body directly as well. But for brain, the concept is that it has an indirect effect on the neurons. What it does is that it affects the leukocytes which we have in the blood, and they cross the blood-brain barriers, and then they affect the microglia. These microglia, when they get affected, they become very angry and they release the products which causes damage to the oligodendrocytes, and thereby there is a decrease in the myelin production, and that results in the cerebral volume loss. And then there is a myelin decrease in the myelin, then it indirectly kills the neurons as well. So it is an indirect affection of the neurons, and this is the correct answer, that we have the activated brain macrophages and the microglia which attribute to the cerebral volume loss which we see in patients who are affected with the HIV. Now, what about this? ART with high CP score increase neurotoxicity and should be avoided. So should we avoid drugs which have got high CP score? So what is the concept of CP score in antiretroviral therapy? So we have basically, this is one of the central paradox of HIV infection in the brain. See, the HIV virus binds to the infected leukocytes and easily crosses the blood-brain barrier. So this is very easily, it goes into the brain and then replicates. Whereas the antiretroviral therapy, they have a very limited penetration into the brain. And this can result in a chronic and persistent replication of the virus in the brain despite a very low peripheral plasma viral load. And this is responsible for the neurological, metabolic, as well as cardiovascular and cerebrovascular comorbidities. And sometimes even resistance may develop if may evolve discordantly. So that is why there has been a concept of CPE score. That is, we choose drugs with high CPE score which have got a better penetration. So traditionally it is thought that the drugs which have got high CPE score have a high CNS penetration, and drugs which have got a low CPE score have got a low CNS penetration. So these are the various antiretroviral drugs, and these are given CPE scores as well. So we have zidovudine with a very high CPE score, and we have certain drugs like TAF and TDF which are of the low CPE, and now we also have dolutegravir which has a high CPE score. So there has to be balance between the toxicity and the efficacy. And remember that always the drugs which have got a high CPE score, that does not mean that it is going to have a very effective concentration. Sometimes drugs with high CPE score may be effluxed out, like the protease inhibitors as well. And there has been some recent trials which are published in OFIC 2019 which have shown that there is no impact of the CPE score on the neurocognitive impairment in patients who are well controlled with the HIV. And regarding the concern of neurotoxicity of dolutegravir, so there has been studies which have shown that the neuropsychiatric adverse effects which have been reported with DTG, they are there, but they are not too many. They're just discontinuation which have been noticed in 1 to 6% as in the previous studies. And even in our clinical experience, the patients who have got side effects of neurological disorder is neuropsychiatric, if they are started on the antiretroviral therapy, they do very well and it is very well tolerated. Now with this, I think...
Would you like to throw some light on megahertz, particularly for PMLE, use of more than 3 drugs in antiretroviral therapy?
For PMLE, more than 3 drugs?
Yes. There were some studies on use of megahertz, which is called as adding AZT to your current therapy. Even with your low CP score, you add AZT onto that.
Yeah, that is there, like if you use, but in my clinical experience, it has been like the triple drug therapy, especially TAF, the TDF, TAF, they have also been very useful. But yes, for PMLE, especially like adding like zidovudine along with lamivudine, and of course with DTG, these are the drugs which can definitely help in the recovery of the patient. DTG, definitely, yeah. So I think in the interest of time, I'll just quickly go through this case which has in collab, or shall I wind up?
If you can discuss in 5 minutes, then it will be.
Yeah, sure. So it started on, yeah. Shall I go or
Yes,
I'll wind up? Okay, so quickly, this is a 26-year-old gentleman. 2016, he had a right hemothorax and the ICD was inserted, and he had developed empyema on this. And that's when he had undergone this VAT surgery and a drainage, which was done by the CTVS team. And this was the tissue culture which was noticed. We have this Klebsiella pneumonia here. And as we can see here, this is a carbapenem resistant Enterobacteriaceae. We also have a Staph aureus here. Now, when we have a Staph aureus, what do you think this is? This is a MRSA, right? With oxacillin resistant, this is a MRSA. Now, this patient was on meropenem, colistin, as well as tigecycline based on the susceptibility pattern which we have here. So, which was colistin, meropenem, as well as tigecycline. Now, in this patient, despite on all these broad spectrum antibiotics, he was still having this persistent right-sided effusion, and that's when the surgeon referred to us. So what do you think the choice of antibiotic should be in this patient? Should we continue with merocolistin as well as tigecycline? Should it be colistin, tigecycline? Should it be colistin, minocycline, IV minocycline? Comments from the audience, please. Yes, of course. Staphylococcus aureus, MRSA.
Doxycycline is not a gram-positive antibiotic.
It has a static effect on the GP.
No, but if you have to do a cycle, and if it is NMRSA, then you have
It's-
to go to either ticoplanin or vancomycin. You should not be giving these 3 antibiotics or 4 of them.
Yeah, point absolutely taken, sir. And definitely a sidal therapy is needed or would be required if there is a high inoculum. But a lot of times we do consider, there are several factors which we consider. And one of them, the table just summarizes this. We need to look into what is the spectrum of activity and also look at the bugs which are not being covered by the antibiotics which the patient is on. Like Dr. Nitin suggested, like meropenem is on and the patient is still febrile. So there is a bug which is not being covered or is resistant to that. So we also look at the lung concentration which is being, which is, or this, the penetration at the site of infection of that particular antibiotic. And right now we are talking about the lung penetration. What are the various susceptibility as well as the MIC breakpoints which we have, and of course at the same time look at the possibility of oral conversion as well as the cost to therapy. So here in this patient, colistin, as we know, covers only GNB, has no activity against the GPCs or the anaerobes. We have tigecycline which has activity against GNBs, GPC, anaerobes as well. Here of course it is static, but when we look at the penetration in the lung, very poor penetration, and that is why it is not even included in the guidelines for treatment of a VAP. We look at other, when you go back into it, we have to actually look beyond the antibiogram. There is no mention of the minocycline in the antibiogram which was presented here, but when you look at the Staph aureus, so you have tetracycline which is sensitive. You have a tigecycline which was mentioned sensitive, but you have a tetracycline. So if tetra is sensitive, minor is going to be sensitive. So this is just beyond the, and look beyond the what is visible as well. So minocycline is again has the same spectrum of activity. It has no, it has a very good and moderate penetration or a good concentration into the lungs. And it is an age-old drug which has well-defined susceptibility breakpoints as well for the MRSA as well as for the gram-negatives. And it is a drug which has got a very good oral conversion. Now, ticoplanin definitely should be, if you have only MRSA there, and then this is one of the drug of choices also, but it has no activity of GNB against GNB. So we're looking at drugs which can actually have just one. So this patient had undergone a good source control. Remember, source control is very important, and then adjust the antibiotics. So we discontinued all of them. Patient was shifted to IV minocycline for 2 weeks and then converted to oral. And he had this very beautiful response over the next few weeks. And the cost of therapy was significantly reduced. So with this, I think I will summarize and sure.
Gram-positive Staph aureus. Tigecycline is not a tissue antibiotic. It rapidly disappears from the bloodstream.
Agree. It is not a bloodstream infection.
Okay.
Tissue antibiotic.
I agree. But
Yes.
here you have a person with the hemothorax also. And what I'm trying to say is that minocycline is not, and neither is colistin or any, they are not sidal drugs. Sidal drugs are vancomycin and ticoplanin. So you did not use either vancomycin or ticoplanin in this patient.
Correct.
You were lucky you got away with it. But if this patient came to you again with an empyema, then you must use something against gram-positive.
So here, as I mentioned, source control was done. I completely agree with you. And at the same time, sidal and static concept is again, we definitely need it if a patient is having febrile neutropenia or low endocarditis where the penetration is not good of the drug. And in this patient, because the premise was, the idea of discussing this case was that how we can look beyond the anti-diagram which is available to us, look beyond it and try to interpret and use single drugs rather than multiple drugs on board.
Thank you, Dr. Neha Gupta, for presenting. You want to make some comment?
just wanted
For
to-
very interesting cases. Wish we had more time to discuss these. But
Yeah,
thank you,
I
sir,
think,
for your
yeah.
inputs also, and audience on particularly on the HIV case. Thank you.
Thank you, ma'am. I would like to move to the next. For the next session, I would like to invite Dr. Mugdha Tapadia. She is a senior physician in Fortis Memorial Hospital, Gurgaon. And to deliver the talk, an interesting case, Professor Dr. Vikas Suri. He is a professor in medicine in PGI Chandigarh.
Good evening, everybody. A big thank you to Dr. Neha, Dr. Gobia, and Dr. Nitin for giving me the opportunity to come here and speak. But I come from PGI Chandigarh, and when I was discussing what to present, because there's a whole lot of sessions on interesting case sessions. So I asked Dr. Neha what to present. I had a whole gamut of rarer cases, ranging from toxo to fungus, because we are a center for advanced fungal infections. But ma'am said it's better to discuss a common disease which we probably treat every day, and yet to see two people, or especially internists, treat it with the same drugs. So can I have the slides, please? It also gives me a special thing that I'm presenting in front of Dr. Mugdha. Dr. Mugdha is my senior from my wife's institute, and she's a very good friend of my sister-in-law. So it's always also gives me a little more pressure to present. अपने मायके के सामने present करना और मुश्किल हो जाता है. So I'll be presenting uncommon presentation of a common infection. So we had a 23-year-old male who presented to us with pain abdomen that was mainly in the left upper quadrant. It was a dull aching intermittent pain. It was associated with fever. It was high grade. It was persistent for the last 2 weeks. Initially, they say that it was low grade, but for the last about 7 to 10 days, it was high grade. And was associated with chills and rigors. His personal history, past history, he was a reformed smoker, non-vegetarian, and past history was he was a pretty healthy man, and he used to run around, and he was a student. When he came to our emergency, he had tachycardia, he was tachypneic, he was febrile, and he was shifted to our ward. We have we work at a government institute, so we have a ward, infectious disease ward, so-called 10-bedded ward. So he was shifted to our ward, and he had normal saturations on the room air. His cardiovascular, respiratory, and the CNS infections were within normal limits. And a per-abdominal examination revealed a spleen which was palpable 3 centimeters. We still believe in physical examination because we belong to a teaching institute. We still feel that palpating spleen is more important at the first for the resident. So it was palpable spleen 3 centimeters below the left costal margin. It was firm, tender. There was no organomegaly, and there was no shifting dullness beside this, signifying no free fluid in the abdomen. He had tachycardia. He had mild transaminitis. He had a high CRP. Now, thanks to COVID, we get CRP in every possible case where fever comes. Initially, when I was a resident, CRP was a very expensive test and was not available in many of the laboratories. And now CRP is done as a routine test for acute febrile disease. He persisted up to day 14. I'll tell you why. And then it decreased. So he had an ultrasound abdomen, which was done in the emergency, which revealed splenic lesions. There was a large lesion at the interval area. There were 4 small anechoic lesions, and the possibilities were query necrosis or evolving abscess or infarcts. As 2 of radiologists, they confuse you, and they coax you to do a CT scan. So we did a CT scan after shifting to our ward, and it revealed these lesions, confusing lesions, no definite walled-off lesions. There was peripheral lesions, there were wedge-shaped opacities, and quite a big part of the spleen was involved by these lesions. So we were confused. It's query infarct or an abscess. And it is said that if the fever is persistent and if you can demonstrate bacteremia or sepsis, then it is most likely an abscess. If it is single lesion, then it is most likely an abscess. Multiple well-defined maybe abscesses or maybe infarcts. But if you can demonstrate a vest-shaped opacity, then probably it may be infarct also. But if you aspirate a purulent material, it clinches or most likely diagnosis of a splenic abscess. But again, there's a caveat. Medicine, nothing is absolute. Well, this study shows that if you see the causes of splenic infarction, more septic emboli also constitute one of the important etiologies, and we can isolate organisms, again confusing us whether splenic infarct or splenic abscess. What was splenic abscess? This is a recently published from US in 2021, in which they reviewed 33 cases retrospective. For splenic abscesses, the most predisposing factors are diabetes, pancreatic diseases, and as expected, the most common isolates were E. coli, enterococcus, and anaerobes. Interventional radiology helped us in 17 of these patients, 6 underwent splenectomy, and treatment success was achieved in 14 of the 32 cases. We have a publication from our institute. It was a teamwork between Department of Internal Medicine, gastroenterology, gastrosurgery, microbiology, and interventional radiology. And out of the 36 patients, which it was a prospective study, comorbidities, the common isolates were gram negative. Salmonella typhi was isolated in 9 patients, that is 25%, and no organism was isolated about 33% of the cases. They had 1 case of tuberculosis, that AFP gene expert positive, and 1 fungal splenic abscess also. The predisposing factors were more or less the same, except ongoing salmonella infection was one of the predisposing factors in 7 of those 36 patients, and no factor could be predisposing factors could be associated, could be found in about 9 cases, that is 25% cases. So coming back to the index patient, Vidal was positive. The procalcitone was 3.5. The patient went for a single time aspiration from the splenic lesion on day 2 of admission, which revealed 20 ml of pus. There's quite a large amount of pus which was drained. The gene expert, the fungal smear, and gram stain, everything was negative. The blood culture, 3 sets were sterile. As part of the workup for all patients with splenic abscess, we get an echo. We got a transthoracic and a transphageal echo because the possibility of infected carditis was quite high, but it was normal. We have a good center for immunodeficiencies, though he was a young patient. His NBT was negative, and ANA ANCA as part of non-infective causes because the possibility of splenic infarction was there. So we even got a workup for a non-infective cause of this APLA workup, and everything was negative. So now the pus culture came. The pus culture revealed Salmonella typhi. So it was after 5 days of culture, 5 days of constantly calling, thanks to microbiology, and we got this culture positive. So if we did the management timeline of this patient, day 1 he had fever. Day 2 he was, as part of a protocol which I'll be illustrating in the later slides, we put all patients with splenic query abscesses on a broad spectrum Phalosporin, that is ceftriaxone. Day 5, we had a pus culture with Salmonella. We continued ceftriaxone. We added azithromycin. We gave a combination therapy because we thought that though we didn't have a culture positive. The fever persisted at day 14. He had persistent leukocytosis. He developed mild hypotension. So we decided this. We got the surgeons into picture, and the patient underwent a splenectomy. Post-splenectomy, day 7, he was absolutely fine. Was discharged and sent back home. Well, the splenectomy specimen received necrosis. There was neutrophilic infiltrate. There was small areas of infarction also, but it was predominantly microabscesses, suggesting a splenic abscess. Most likely, it is because of Salmonella. So, final diagnosis in our patient was a fewer multiple splenic abscesses, pus aspirates suggestive of Salmonella, and the patient underwent a splenectomy. So, my points of discussion would be management of splenic abscesses. What is new in Salmonella? And I wanted to add a section about post-splenectomy vaccination in my presentation because that's an important aspect when you are managing a patients, especially who have gone an elective or a emergency splenectomy. So manage of splenic abscesses, we have a protocol in place in our, though I'm sorry for the basic slide, but we have a protocol in our hospital that any patient who comes with splenic as well and where splenic abscesses are high on cards, we get an imaging which is initially an ultrasound followed by a CT scan. We send a full septic profile, that is blood cultures, and we send the other investigations as part of the fever workup. The patient is generally started on third general cephalosporins or piptox and dasbactam. We started our patient on ceftriaxone. So depending if it's a single abscess, it's less than 5 centimeters, we go ahead with a single time aspiration. If it is more than 5 centimeters, the interventional radiologist then they take a call on putting a percutaneous drainage, or they can go ahead with a single time aspiration. Our patient, they were not very comfortable because there were multiple lesions, so they went ahead with a single time aspiration. If the patient is not responding to 40 to 72 hours, we call the surgeons, and then they take a call whether to go ahead with splenectomy. But if the patient, there's a ruptured splenic abscess and the signs of peritonitis, the patient undergoes an emergency splenectomy. If there are no signs of peritonitis, then probably we can try a percutaneous drainage, and then if there's no improvement, we go ahead with a splenectomy. So this is the management protocol which we follow for probably splenic abscesses in our hospital, and it's quite working well in our hospital. The second part is what is new in Salmonella. Well, any microbiologist, I'll take about 5 minutes more. There's a change in nomenclature. Well, the first is the Salmonella, second is the subspecies, and then is the serovar. Initially we used to write all in italics and the T was small. So now the T is capital and the P is also capital, remember, and it is not in italics. So this is the nomenclature. In microbiologist, I may be corrected. This was the interpretation I could get after reading the latest nomenclature about Salmonella. The diagnosis, depending on the time when the cultures are taken, the sensitivity and specificity increases and decreases, but the gold standard is still the bone marrow culture, but it is very less specific. The huge gamut of immunological tests, new tests are added every day, and depending on where you are working, I work in a tertiary teaching institutes. I can easily say I don't, because Cochrane View doesn't recommend the immunological tests, so I can say that you don't need to treat these immunological tests if you have fever. But depending who is calling you, like a VIP calls you and if a typhoid positive, you might end up giving him an antibiotic. But we try to follow evidence-based medicine as much as possible, which is in our hands. So the Cochrane View said that all these tests are of no use and no robust data is needed. What about multi-drug resistant? We call it multi-drug resistant Salmonella, which is resistant to ampicillin, chloramphenicol, and ceftriaxone. Then we have flocal resistance, and we have third general cephalosporin resistance. Also, we have an XTS strain which was first found in Nepal, and then there were 300 cases outbreak in Pakistan, and there are 1 or 2 cases reported from India also. This is a strain which is resistant to ceftriaxone, is sensitive only to meropenem. This is the trends of MDR Salmonella. This was published from JIPMER in 2009 to somewhere in 2012, in which the MDR was about 22%. But a recent publication from CMC Vellore shows that the MDR resistance has come down to 2%. And luckily, all the 100% Salmonella paratyphi were sensitive to the first-line antimicrobials. Azithromycin has nearly replaced ceftriaxone for uncomplicated enteric. And beta-lactamase, lactam and beta-lactamase inhibitor show potent in vitro activity, and they may be used for the XDR strain. Treatment, I've already told about azithromycin, which is probably related a 7-day course for uncomplicated enteric. Well, there's a combination therapy, trial on combination therapy, results are awaited, but there's a concern that combination therapy of ceftriaxone and azithromycin may promote resistance. Should I go ahead with it or should I stop? I can stop.
Wrap up it, 1 or 2
I think so. We'll stop. Vaccination will stop. Any questions? So it was 11. It was normal, sir. There was.
Yeah, Dr. Suri, you had a very common topic, which is everybody is treating it day in and out. The only thing I wanted to ask you was, how have you seen any ceftriaxone resistance at your center?
No, not till
that
now.
is what we have started
Not till
seeing.
now,
So
no.
that is a concern. Yes. So that is what is a growing concern now. Yes. Yes. So that's why I want
Not
to
till
ask.
now.
India is a big.
Well, there's a study going on with Dr. Pallab Ray, Dr. Madhu Gupta, and they're collating data. They're doing a community survey also, and all the reference center, they probably the results will be analyzed and published.
We already have around 8-10 cases in
Yes.
this auditor in this hall only. So
We get a lot of
15 years,
occasional paratyphoid, especially when they have taken dairy products.
Yes. Sir, we can discuss this.
Yes.
Over the
Thank you, Dr. Vikas, for wonderful
you.
presentation.
For the next session, I would like to. Next session is also on a panel discussion where we will be discussing cases. I would like to invite the panelist, Colonel Dr. Kuldeep Astha. He is from the Army Hospital, vastly experienced in medicine and HIV. Dr. Jitendra, intensivist. Dr. P. Venkat, senior physician in Artemis Hospital, Gurgaon. To discuss the cases and present the cases, I would like to invite Dr. Suneetha Narreddy. She is a senior consultant in infectious diseases in Apollo Hospitals, Hyderabad, and founder member of CIDS. Yes, ma'am.
Thank you. Can you hear me now? Yeah. Thank you, CIDS Delhi chapter, and especially Dr. Neha and Dr. Nitin for having me over here. And respected panelists, thank you. So, excellent presentation by Dr. Vikas Suri, and I'm taking over from him. So I'll probably cut short my presentation of one of the cases. And we've discussed a lot of ID. Now, what I'm going to do is just go to the basics. Go to the real basics. I'm not going to talk about anything hi-fi. So let's see what we can do. So I'm going to present a couple of cases. So 32-year-old male who had presented with fever for 2 days. What will you do? Just the basic. Young person coming with fever.
Yeah. I think we should not do any tests. Just treat him symptomatically and maybe do a WBC count. And if the clinical setting is there, if the fever is with chills and rigors, then I would do an MP first. So basically undifferentiated fever is like malarial and non-malarial. So you start with the malaria and then go on.
Okay. Any other thoughts from any of the other panel members?
It depends that what is the kind of situation we are in, like if you are having a dengue epidemic or something like that. So chances that a fever coming with this is likely to be dengue 99%. So if you want, we can do a test. Otherwise, in a normal OPD time, a person coming with 2 days fever, we can wait for 3 days if there are no specific symptoms contributing.
Sorry, I may be a devil's advocate. I'm a primarily intensivist. So this much information is really inadequate for me. I'll treat the patient. Suppose the patient is really unstable at the time of presentation. What is the other physical examinations? It's really giving me yours, because if it is going to a severe illness, and if I pick it up, maybe on the clinical background, or maybe what is the other detailed history, that can give you so take it as a balance. Of course, doesn't require test all the time, but should not be a reservation. You have to have a complete understanding. If it is giving a clue of it is a just initiation of the severity of illness, then you get.
Excellent points. So let's see what the data shows. Whoever is keeping the timer, just remind me at 25 minutes, please. I'll stop at that point. Okay. So what do we know about acute febrile illness? what are the differentials? If you want to classify them, you have acute localized infections where you have localizing symptoms, then it's no longer undifferentiated illness. Or if you don't have any localizing symptoms, then you're calling it as acute undifferentiated illness. If you're looking at acute undifferentiated illness, one of the things that you exactly mentioned is malaria is one thing that you would be considering. And then the non-malarials, which can be viral, bacterial, or parasitic. So if you look at just a mnemonic for trying to understand remember what this for the students out there, you can remember this mnemonic: MAESR, M for malaria, A for arboviral infections like dengue, chikungunya, Japanese encephalitis, Zika, yellow fever, enteric fever, E for enteric fever, S for spirochetal infections, and R for rickettsial infections. So in terms of how do we handle this situation? There's actually a study done, I think this was in Manipal Institute. So this was a protocol that they tried to come up with for acute undifferentiated febrile illness in India. It was a 6-week study. So the protocol that they used in this study was, first of all, if somebody comes to the emergency room with fever, see are there any features suggestive of sepsis. So if there are features suggestive of sepsis, then no longer stable, follow the sepsis protocol. If there are no features suggestive of sepsis, then are there any localizing signs? Then treat appropriately. If no localizing signs, what is the day of the fever? If it's day 1 or 2, defer investigations and antimicrobials. Day 3 or 4, do some basic workup. Or if it's longer than that, then you add blood cultures and other investigations as required. So this was a protocol that they had established. And based on that, they had about 200 and odd patients, most of them presenting in the first 1 or 2 days. And majority
with the paracetamol. The abuse of antibiotics starts with 2 days of fever. So that is what is my point is when I was saying that I would not do anything, just giving paracetamol for 2 or 3 days, and we start with the investigations on day 1. Malaria, differentiate. Malaria is a very sensitive investigation. The card tests are quite sensitive, and then so on and so forth. We go on and treat if it is. We had a wonderful article on undifferentiated fever in JAPI just recently, where they gave out wonderful guidelines as to how to manage any acute undifferentiated fever.
So pretty much that's what we're talking about here. And majority of them diffused without any need for investigations in this study. And again, this, if you look at the final diagnosis, most of them had non-specific, about over half of them. And this was again, they validated this fever protocol in another study as well. So I'm just going to cut short this in for interest of time. So one of the first duties of the physician is to educate the masses not to take medicine. This is very, very important, I think, for us. So, okay.
William Osler only said that, listen to the patient. He is telling you the diagnosis.
Absolutely.
So that is the, basic funda with acute undifferentiated fever.
Absolutely. So moving on to the next case.
A 57-year-old male who presented with headache, retroorbital pain, body ache for 3 weeks, high-grade fever and chills as well for 3 days. On examination, he had a temperature of 102. He had conjunctival suffusion, had diffuse blanching rash with generalized erythema on the chest and back, as you can see here. And this investigations were already done by the time he presented to us. And as you can see, his platelet count was slightly on the lower side. And as along with his white count being a little low, his transaminases was slightly elevated. What is the most likely diagnosis at this point? Okay. So what is the investigations that you would like to do at this point? NS1 antigen or dengue IgM, dengue IgM, IgG, NS1 IgM, IgG, blood culture, what exactly would you like to do?
I think we'll just go with NS1 antigen. There's no point of getting a dengue IgM in the beginning itself, unless you're doing an ELISA on it.
Yeah. So again, just to go over that, we have to be judicial in choice of investigations. To understand that, initially you have the viremic phase. This cursor doesn't work there, is it? Okay. Initially the viremic phase, and NS1 will be positive in the initial phases, followed by a few days later is when your IgM will be positive, and IgG is really not useful in the acute phase at all. Okay. Sensitivity of IgM is also greater only after day 5, so you do not want to do it before that. Okay, another picture for the same thing. And there are different ways you can do the tests. NS1 can be a rapid test, which has a shorter turnaround time. You can do an ELISA, which takes about a day, or immunohistochemistry. And again, if you're talking about the IgM, you have both the ELISA and the rapid test as well. Okay. Okay. So what are the warning signs? When will you really want to admit patients into the hospital if they have dengue? That's very important to consider. Would you like to say some points here?
The warning signs, especially hospitalization and that too in the ICU, they are the very, very categorically over there. When the organ, the involvement of organ is there, especially once we start with the kidney manifestation, oliguria is the one of the important, and the high grade signs with the altered sensorium. These are the few clinical signs based upon that, and the laboratory values depending upon the what is the age group of the patient. So it is a categorized according to the what is the age group and the medical status, and then the what is the severity of this thing is. It varies from milder form to organ involvement, liver dysfunction, myocardial dysfunction, hematological manifestation, to a complete frank circulatory shock distributed.
Actually, once we get a patient of dengue, the most of the people, they only, you forget the warning signs lot of times. If the platelets are normal, the patient is, मतलब platelet के ऊपर इतना ज़्यादा obsession हो गया है कि it is, whereas we forget that he's come with pain in abdomen and he's vomited thrice. This may be a sign of impending
serositis
issue.
So being an intensivist, we have seen is the mortality happens because of the shock. We hardly see a thrombocytopenia causing death. Hardly see.
And usually
few unfortunate people have
an
intracerebral hemorrhage. Otherwise, it is a multi-organ dysfunction in the shock.
As a physician, if a patient of dengue walks into my clinic, it's this epidemic season and I suspect it's dengue. So what I actually look for is, one is the blood pressure of the patient. If the blood pressure is in shock, needs admission. Second, is the patient accepting orally adequately or not? If the patient is not accepting, he is dehydrated, he is vomiting severely, then that is a relative indication for admission, because orally we cannot hydrate him adequately. Third, if there is a major bleed from anywhere, there's a parectal bleed or the menstrual bleed is ongoing, which is not getting controlled, then we can relatively admit him for management of that. And fourth, they get some tests if they are done and the transaminases are very high, the patient might be going into severe hepatitis or organ involvement is there, like renal dysfunction is there. Then platelets is not one of the criteria for admission at any point of time. That should be very clear.
So to summarize the warning signs, primarily abdominal pain, vomiting, bleeding, fluid balance, enlarged liver, rise in hematocrit is another thing that you have to worry about.
Treating the dengue patients. Similarly, like we have to do a frequent clinical examinations of the patients because at one point of it's very easy to categorize on the literature, but the patient, what is their state, how he was partially resuscitated. The most important thing is the patient once partially resuscitated looks better than the previous kind of appearance, and then later on again it deteriorates. So fluid management, initially it is a distributive shock. We require a lot of fluid. Lot of fluid means is really we have to be on the bedside all the time to see the really fluid is going on. It can varies from 6-8 liter to 14-15 liters per day for adults. Over the time period when this capillary leaking goes down and the deresuscitation phase comes and the organ dysfunctions happens in another way. Similarly, the kidney dysfunction can happen as a part of the a pre-renal cause on the initial phase. Later on, it's purely because of the viral manifestation of the kidney dysfunction. It happens, then we have to deresuscitate the patient. So in the recovery phase, we have to remove the fluid, if possible with the diuretics, or may require a renal replacement therapy. All kidney dysfunction at that moment doesn't require fluid replacement. In fact, it would be a counterproductive for those patients.
How many of us genuinely do multiple times postural blood pressure testing and ask our residents or go when we go on the rounds that it has been done? It's an extremely important test, and even when we are fluid resuscitating, it's a very good test. The moment the postural hypertension starts to go, the patient recovers very beautifully. All of us must have seen that, those especially who do that. And secondly, I feel that regarding fluid resuscitation in dengue, should be a judicial combination between using inotropes and fluids. Going overboard with fluids only and not using at the appropriate time because there is severe capillary leakage. We must, use inotropes at a slightly early stage once we have started the fluid resuscitation.
In terms of choice of fluids, would you have a preference of what particular kind of fluid?
So technically, classically, of course, as he said, now we resuscitate all the patients with the help of the advanced hemodynamic monitoring. It not in even the one hemodynamic monitoring, the combination of the hemodynamic monitoring where the frequent echo assessment and all is being done. Doing so in our last 10-year practice, then we really came to know significant number of the patients having a myocardial dysfunction in the. So again, it is a combination of the inotrope, vasopressors, and the fluid. Specifically, which fluids? Primarily, mainly based upon the crystalloid. Now the crystalloid, again, there are again a lot of monitoring over there, electrolyte based and all these things. So gradually we are moving to the low chloride based crystalloid. That is a balanced salt solution. These are the mainstay of our classical resuscitation.
Okay, thank you. Let's move on. I'm going to pass to this. Okay. Couple of important points. No prophylactic platelet transfusion is required. There's a lot of studies regarding this. Cochrane data review as well in this, saying that we do not need to give platelet transfusions. They have tried antivirals like balaprevir and selgosivir. Both were negative studies. Steroids are not justified, and IVIG is generally not required. Just going to move on. So do's and don'ts: don't use corticosteroids, don't give platelets unnecessarily, don't give half normal saline, don't assume that IV fluids are necessary. Inform the patients what to do, what to anticipate, and what are the warning signs. Recognize the critical period, monitor the fluid, recognize shock, administer colloids only for refractory shock, and avoid blood products unless there is significant bleeding. Okay, we're going to move on. Okay, next case. 25-year-old male had fever for 4 days, chills and rigors, no other localizing symptoms or signs. His hemoglobin was 10 and white count 10,000, platelets 1.2 lakhs. His malaria antigen was positive. He was treated with ACT. He completely improved. He's asymptomatic now, and he gets a repeat malaria antigen test, and it is positive for Plasmodium falciparum after 2 weeks. And he comes to you because he's done his test and wants to know what to do now. What do? You retreat with the different ACT, give chloroquine, ignore and reassure, or give quinine and clindamycin.
Same thing with Vidal, Typhidot, same thing with Plasmodium, malarial antigen test, ignore and reassure. That's the only thing that would say the test will come positive for maybe 2 to 3 months or later. There's no point of repeating it. It's an antigen test. It is not a parasite test actually.
So again, to understand that you should know what test to order, when to order, and what is not to order. We started this first lecture today with diagnostic stewardship. So it comes to that.
Can I make a...
Yes, sir. Yes, sir.
In falciparum malaria, gametocytes will persist for many weeks after you treat with ACT. Yes. And the gametocytes have the same antigenic structure as the... So that's one reason why you're getting a malaria antigen positivity. Now, unless you give primaquine
that's one
following, then only you'll get rid of the malaria antigen positivity.
Yeah. So that's the other point that we have to learn from this case. Okay, so just to go with the rapid diagnostic tests, they're immunochromatographic tests using monoclonal antibodies to detect the enzymes produced by the parasites. So there are histidine-rich protein or the LDH, plasmodium lactate dehydrogenase. The histidine-rich protein lasts in the blood for a long time as compared to the lactate dehydrogenase and is present primarily in the falciparum, in which case it will be present for a long period of time. So I'm going to move on faster here. Okay. This is a case of typhoid, so I'm going to ignore this because we just went through this. But point to say that blood culture is the most important test for typhoid, and the other tests are not reliable. So I'm going to skip this because we've just had a long discussion on typhoid, and of course again we talked about the drug sensitivities as well. Okay, 34-year-old male who presented with no comorbidities, had come with no comorbidities, came with high-grade fever, joint pain, loose motions, and icterus for 3 days. He had breathlessness and hemoptysis. He was in severe hypotension with a blood pressure of 60 and hypoxic, had to be intubated with requiring a high FiO2 of 95% and was inotropes. So otherwise, well person who had a pretty short history of fever, joint pains, loose motions, jaundice, went on to be in shock. So this is a picture of the conjunctival hemorrhages and petechiae, as well as pulmonary hemorrhage. I don't have the missed one picture here, but and his white count was elevated, platelets were low, creat was high at 3.1, potassium was high, bilirubin was 6.2, transaminases was slightly elevated, and malarial test was negative, dengue test was negative, leptospira IgM was negative. So when we went back and took more history, they said that he had also complained of myalgias and he was wading through rainwater. Any clues from this? Anyone wants to take a chance? Yes, sir. So again, so leptospirosis, your treatment of choice, penicillin followed by doxycycline for severe. And do you have time for one last case?
Yes, ma'am.
Okay, 35-year-old male who presented with from Hyderabad with fever for 8 days, high-grade fever with occasional chills and no rigors. Also had headache, vomiting, and cough and myalgias. He had traveled to his village in a neighboring district about 2 weeks prior to his presentation. And before he came to us, he was treated with ceftriaxone and Piptas for 4 days without any improvement. His temperature was 102, otherwise he was relatively stable. On cursory examination, there was nothing major that was found. And his platelets, as you can see, was low. Transaminases were elevated. His spleen was enlarged. And investigation, again, initially, malaria, dengue, leptospira were negative. Blood cultures were sent off. CT abdomen showed some splenomegaly. So what is your diagnosis?
Can you go back to your initial first slide with the symptoms?
High-grade fever, headache, vomiting, cough, and some myalgias. He had recently traveled about a few weeks prior to the presentation, 2 weeks prior to the symptom onset, he had been to his village. So, no, I didn't give the options. I just left it.
Here, this one.
Yes.
Could be still enteric fever.
Could be enteric fever. So if you really did a proper examination, you found an eschar, and then diagnosis of scrub was made based on that. He was started on doxycycline and he's promptly improved. So eschar is seen in a lot of patients. You have to know where to look for and go. So this is the places where you can find the eschar, just to give an example. And you have to look for the eschar to diagnose the scrub. Clinical examination is very, very important. Just don't depend on labs all the time. So again, come back to the basics. So I think I'm going to stop here in the interest of time. And I'll take any questions if you have. So treatment for
like everybody does. You go for 4 days of fever and somebody will start you ceftriaxone, you search another doctor, he will put you on Pipta.
Exactly. That's what happened.
What is your opinion on Wheat-Phillips test? We'd like to know.
Not 100% sensitive test. I always connect. All the investigations should be correlated with your clinical picture. If clinical picture is suggestive, yes, I will consider it. But otherwise,
Blood typhus available. Will you still send a Wheat-Phillips test?
No.
So Wheat-Phillips is
not available.
But has it got some sensitivity?
So if it is positive and the clinical picture is matching, I will take it. If it is negative, it's negative. I'll still go with the clinical picture. So to summarize, just a little bit differentiations between the various acute febrile illness, dengue, malaria, typhoid, leptospira. Just look at the duration of symptoms and other features of exposure. Have they been eating outside? Where have they traveled? What is the response to various treatments that they may have received, and presence of rash, other clinical signs like conjunctival suffusion and eschar. And if you look at the labs, monitor hemoglobin for dengue. I'm not saying platelets are actually monitor. Hemoglobin more important. Your white count can be low in dengue and typhoid, usually high in lepto and scrub. Platelets will be low with dengue or lepto and scrub malaria as well. Transaminases are very useful. LFTs are generally way more useful than a lot of other investigations in my mind. I don't know how others feel on that. Okay. And I thank my team for helping me with my work and as well as this presentation.
Thank you, ma'am. Thank you, Chairperson. I will move on to the next session from diagnostics to therapeutics. I would like to invite Dr. B.B. Rewadi sir again to please chair this session and to speak on post-exposure prophylaxis and pre-exposure prophylaxis. I would invite Dr. Pooja Khosla. She's a senior physician in Sir Gangaram Hospital and a specialist in HIV with lots of experience and publications in HIV. Over to you.
So, good evening, everyone. I will be talking about prophylaxis, pre and post. So, although HIV epidemic is on decline, but still about 2 million HIV cases are rising every year. And we have to understand the risk factors of HIV infections. Successful preventive strategies have to be combined with both behavioral and biomedical intervention. And these biomedical interventions are pre and post exposure prophylaxis. Now, I will start with post exposure prophylaxis of HIV, which is both occupational and non-occupational. Now, post exposure prophylaxis is a short term antiretroviral treatment to reduce the likelihood of HIV infection after a potential exposure, which is either occupational or it's a sexual intercourse. It's typically offered to healthcare provider if they have a needle stick injury, or a non-occupational exposure after a sexual exposure or a IV drug abuse. It should ideally be started within 72 hours, and this has to be continued for 4 weeks. Now, we need to understand non-occupational and occupational estimated risk transmission of every single prick. The needle stick has 0.3%, receptive anal intercourse is 0.5 to 3%, receptive vaginal has 0.1 to 3, insertive anal and vaginal have lesser incidence, 0.06 and 0.05, and receptive oral is far less. Now, steps for managing an occupational exposure. Now, as soon as there's a possible occupational exposure, wash the site liberally with soap and water, be it any skin, eye, or mouth. After that, you have to establish the PP. If the exposure is within 72 hours, you have to assess the exposed person as well as the source, and then assess the type of exposure. Determine the type of transmission, then you have to see if they are eligible for PEP. Provide the information of HIV and PEP, and then you take the consent of PEP. Then you have to assess the patient's ARV status and check for pregnancy if you're dealing with a female healthcare worker. Simultaneously counsel them for the side effects of ARV. Check them for HBsAg, HCV, as well. Do a proper pre-test counseling, check for the immunization of hepatitis B, do the routine testing, and then after you've given them ART, do a follow-up, which we'll be discussing. Now, occupational blood exposure, relative risk of seroconversion with a percutaneous injury, it follows the rule of 3, 0.3% with HIV, HCV is 2 to 3%, HBsAg, without activity is about 30%, with activity much more. Now, at risk is exposure. Occupational is either percutaneous injury, which can be with a hollow or a sharp needle. If there's a visible blood or high viral load, deep injury, or if the device is in the vessel. And then there can be a splash on a non-intact skin or on a mucous membrane. And sexual is mucous membrane from a sexual exposure. Now, the category of exposure again is mild, moderate, severe. You categorize them, which will help you plan PP. Now, this is an important slide. A substantial risk of HIV acquisition is there. You have to keep in mind when the source is positive, if they come in contact with blood, semen, vaginal secretion, rectal secretion, breast milk, or any body fluid which is visibly contaminated with blood. And the exposure area is vagina, rectum, eye, mouth, or any mucous membrane or a non-intact skin and percutaneous contact, then you have to offer PP. But if the source patient is of unknown HIV status, then you have to determine case by case. Now, if the exposure time is over 72 hours and the possibility is low, then there's no need to recommend PP. And especially if you're dealing with secretions like urine, nasal secretions, saliva, sweat, tears. Now, when patients offered PP, you have to counsel the healthcare worker to be very cautious, use barriers, contraception, they should avoid blood or tissue donation, pregnancy, and if possible, breastfeeding, especially when there's a week of 6 to 12 weeks, when there is still no clarity of what is the status. Do the baseline HIV, CBC, renal and kidney test, liver test, serology of HBsAg and HCV, and pregnancy. Also counsel them about the possible side effects and drug toxicity and various interactions. Hammer adherence always. So when is PP recommended? If it's a receptive anal or insertive anal sex, if it's a receptive vaginal or insertive vaginal sex, if it's a non-sterile injection equipment, or if there's a sexual assault or a mixed PrEP doses. So general guidelines to be kept in mind for PEP is therapy is recommended after exposure, preferably as soon as possible, if possible within 1 to 2 hours. 3-drug regime is preferred based on the level of risk. Source of patient's HIV status unknown, you have to decide case by case. Then a follow-up counseling and HIV test has to be done for at least 6 months, baseline 6 weeks, 12 weeks, and 6 months. And you have to see the potential benefits which should outweigh the risk. Now, the preferred regime is TDF with emcitabine, either in combination with raltegravir or dolutegravir. And if we are going for an alternative regime, it's a boosted PI, darunavir boosted, or lopinavir or atazanavir. Now, these are the third drug choices for PEP. But the most important point to be kept in mind, never offer nevirapine, and efavirenz should also be an option when there is no option available. Important points to be kept in mind for PEP. PEP is not a cure for HIV. It's not even 100% effective. And there have been case reports after the use of PEP. The risk of HIV, although it is very small, but PEP should be offered, keeping in mind that it is not a replacement for universal precautions. Complete history of the index patient should be taken, and PEP should be case-based and not driven by a protocol. So I have discussed about the post-exposure prophylaxis. Now I will be coming to pre-exposure prophylaxis, which is also a very important point in preventing HIV. Now, pre-exposure prophylaxis, prepare yourself. It's now pre-exposure prophylaxis. Surprisingly, 1 in 3 primary care doctors and nurses have no clue about PrEP. So not enough healthcare workers are aware of PrEP. But what is PrEP? Pre-exposure prophylaxis is a medicine taken that is taken to prevent HIV infection. People who are at a high-risk behavior, either by sexual behavior or IV drug abuse, they should take pre-exposure prophylaxis. And it has been found daily PrEP can reduce the risk of sexually acquired HIV by more than 90%. And daily PrEP can reduce the risk of HIV infections and IV drug abuse by more than 70%. So we discussed that it is an antiretroviral medication used to prevent the acquisition of HIV in an uninfected person. Who recommends an MSM? Substantial risk of HIV infection, people who have substantial risk of HIV infection, and it's an additional prevention choice as a part of combination of HIV prevention program. Now, very important definition is what is substantial risk of HIV acquisition? when the HIV incidence is greater than 3 per 100 person years, which is found in MSM, transgender women, heterosexual, and men and women who have multiple sexual partners who are not aware of this status. In 2016, it has been found that by using PrEP, it is actually cost effective and cost saving, not even in high risk areas, but also even in a low incidence areas. Now, I will discuss the CDC guidelines. It is approved in MSM, heterosexual men and women, and IV drug abuser. MSM, which are HIV positive sexual partners who have had recent sexually transmitted infections in last 6 months, who have more than 5-6 partners, who the history of inconsistent or no condom use, or are commercial sex workers. In IV drug abuse, again, HIV positive injecting partners and who've taken drug treatment recently. Now, it has, when taken daily, it is very safe, highly effective. Now, a very important point to be kept in mind is the PrEP reaches maximum protection for HIV for receptive anal sex at 7 days and for vaginal sex at about 21 days. And this is the time you have to be very careful, use a barrier method. Now, this slide highlights the same thing. And people who are taking PrEP every 3 months, they should be evaluated for a repeat HIV status, screened for sexually transmitted infections. You should monitor them for renal functions because they are on tenofovir-based regime, hammer adherence, and look for side effects. If it's used properly, it's 90% effective. Now, there are various trials. I'll just rush through them. The EPREX trial, partner PrEP trial, TDF2 trials, Thai IDU trials, they all re-emphasize that there is a significant HIV reduction, and the different arms have been used, TDF, FTC. Now, PrEP Discover trial has also confirmed that TAF can be used.
Pooja, can you summarize the message? Because the time is...
Right. So the message is finally that this is the regime. PrEP is approved, TDF, FTC, and TAF can be used not in vaginal sex, but it can be used in MSM. And then there's an injectable. Recently, Captogravir has been approved as injection. It has a future, and if PrEP is being used properly, we can curtail the HIV infections, and that is what is the need of our. So to be eligible for PrEP, you have to document a HIV negative, and then you should know the HPS-AG status also. And these are this is present, this is emerging, and this is a future. So most important time, a lot of countries have adopted PrEP. We should emphasize on PrEP because that is the answer for HIV prevention. Thank you.
Thank you. These were actually two different topics, so you had limited time. Just to give some updates, it was a nice summary. On PP, you said you can use 2 or 3 drugs. No, we always recommend 3 drugs. Current recommendation is use tenofovir, lamivudine, dolutegravir. That is the preferred regimen. If you cannot use dolutegravir for some reason, you use lopinavir, tenofovir in place of dolutegravir along with tenofovir and lamivudine. And these guidelines, which have been updated by NACO, are now available in website. These were updated in December 2021, but became available, I think, 1 month ago on NACO website. So you can go into that. It is always preferred to take as soon as possible, as you rightly said, within 2 hours, preferably within, if not possible within 2 hours, within 72 hours. That is why it is important for everyone to know where are these drugs available. These are routinely not available at most of the chemists because maybe in big cities, yes, but at smaller places, they are not available. So every hospital has to have some protocols where to get these drugs. Moving to your PrEP, yes, it is a very important intervention, as you said, for preventing new infections, particularly people who are at high risk. That includes men having sex with men, female sex workers, injecting drug users, but anyone at perceived risk, they can take PrEP. And basically, there are 2 types of PrEP. It is a daily PrEP. You can take 1 tablet daily. And as you rightly said, 7 days and 21 is the time for the adequate concentration to be achieved. But there are event-driven PrEP also, which is called 2+1+1. This is for those people who are not at high risk every time, but they think they are going for a high risk activity. They can take 2 tablets 2 hours before the activity, 1 tablet after 24 hours, then another one after. But if the high risk behavior is to continue, then they can convert this to a daily regimen. And for more information, I think you have rightly given the trials. Will not go into details. I'll close it here. Thank you.
Thank you, sir.
Thank
You, sir. We are just 2 sessions away from dinner, so bear with me. For the next session, I would like to invite Dr. Suneetha Narreddy to chair the session. And to deliver the talk, I would like to invite Dr. Ankita Baidya. She is the infectious disease specialist at Manipal Hospitals. The topic of the talk is NNRTI versus PI versus integrase inhibitors. I think it should be long topic, but I hope she does within 10 minutes.
Yeah. Good evening, everyone. So we are, as Nitin rightly mentioned, we are 2 topics away from the dinner, and I'll try to be fast, though it's a long topic. I'll be discussing about drugs and how we can compare INSTI, NNRTI versus PI in different in recent research activities that has come up. So we know these drugs actually binds to different enzymes of HIV virus and inhibits the replication of the virus and integration of the virus in the genome. Human DNA. These are the common drugs, NNRTI protease inhibitors and integrase inhibitors that are available with us, and we are mostly familiar with these drugs. So let us start with first-line ART regimen that is now recommended by WHO in the latest consolidated guidelines in 2021. So it is, we are using dolutegravir as a first-line INSTI along with the NRTI backbone to NRTI is recommended as the first line regimen for the people living with HIV and AIDS. Recently, ODC trial has been done in which it has been recently approved that it can be used in the children who are more than 4 weeks of age and more than 3 kgs. There is an oral dispersible tablets of dolutegravir 10 mg that is approved by FDA in December 2021. And now raltegravir is only preferred first-line drugs in neonates. So again, dolutegravir is now being recommended in the children also who are more than 4 weeks of age. Efavirenz low dose is now considered as an alternative first-line regimen where you cannot use dolutegravir with a preferred NRTI backbone. So alternative first line regimen, we all are aware of. First line, it is DTG with 2 NRTI. In children, abacavir based with along with dolutegravir is what is recommended, and in neonates raltegravir. But alternative first line regimen where we cannot use, I have mentioned about efavirenz, abacavir based lopinavir in children, and recently TAF has been approved where a lower concentration of TAF tablets are approved for children who are weighing more than 20 kgs. So again TAF, but there is a conditional recommendation for it along with the DTG tablets. When it comes to failing first line regimen, it is again based on which regimen the patient is failing. You can go for dolutegravir or a PI based regimen. So to summarize, first line regimen, second line regimen, and third line regimen. So first line, it is mainly the dolutegravir, that's the INSTI, that is a preferred one to start with in your patient if there is no contraindications and to DTG. Apart from this, if you cannot give DTG based regimen, then the role comes of NNRTI, that is efavirenz, that is low dose because it is better tolerated in the patient. And for children, again, DTG tablets are recommended more than 4 weeks. Okay, so this is a study, single study, which compares dolutegravir plus abacavir, lamivudine versus efavirenz, TDF, and emtricitabine for the treatment of HIV-1 infection. So in this study, the endpoint, the primary outcome that was taken was the viral load determination less than 50 copies per ml was assessed at 48 weeks, and the patients were treatment naive patients. So we can see here that dolutegravir is superior to efavirenz with the viral load suppression of around in 88% cases. And in efavirenz, it was 81% cases. But when we see to CD4 count also, again, the dolutegravir has an upper hand over efavirenz with better CD4 response. When it comes to adverse events, only the diarrhea was a concern. Around more than 10% of the patients had diarrhea in dolutegravir arm, whereas in efavirenz, other side effects like neuropsychiatric side effects were more commonly seen. And also the treatment discontinuation was more frequent in efavirenz group compared to the dolutegravir group. So the key points in the single study was that it has a good virologic and immunologic efficacy of dolutegravir plus to NNRTI regimen. It was superior to the combination therapy of efavirenz plus to NRTI combination. Apart from this, the treatment differences were maintained across the key demographic subgroups. And dolutegravir was had significantly lower adverse effects compared to that of efavirenz. Only insomnia was reported in 17 patients compared to 16 patients that was in efavirenz, but that was not statistically significant in the study. Next study was area study, which was done specifically in the female groups more than 18 years of age. And this subgroup was of childbearing age, where they were ready to use contraceptions. The study analyzed at week 48 with the virological outcome. So if I see the inclusion criteria in the study was, as I mentioned, 18 years of age. All the female were more than 18 years of age. They were capable of becoming pregnant and ready to use contraceptions. The baseline HIV 1 RNA was more than 500 copies per ml. And there was negative because in this study they used abacavir. So the patients were, and it was a randomized trial. So the patients were randomized, double-blind randomized trial. So all the patients were tested for HLA-B allele for hypersensitivity to abacavir. So, and they were ART naive or only less than 10 days of prior therapy was there. Risk stratification was done on the basis of HIV viral load and the CD4 counts. So these one subgroup was got the 3-tablet regimen, 1 tablet of azatanavir, 1 of ritonavir, and 1 FDC of TDF and FTC. And the other subgroup got a fixed dose combination of single dose abacavir, dolutegravir, and lamivudine. So this was the outcome based risk stratified based on CD4 count and viral load. So as we can see, dolutegravir was again found to be superior compared to the PI based regimen. In the overall, so 82% had a viral load less than 50 copies per ml when it was analyzed at the 48 weeks of primary outcome. So this was the primary outcome that was targeted, that HIV-1 viral load should be less than 50 copies per ml at 48 weeks in participants that were assigned in both the groups. So if we see, I have already mentioned about this, that it was better. Dolutegravir was again superior compared to PI based regimen when it comes to the virological suppression when it is started in the ART naive patients. Now the Flamingo study, it shows that it was a comparative study between dolutegravir and darunavir based regimen. The boosted darunavir was used along with the 2 NRTI backbone in ART naive patients, and 48 weeks data was analyzed. So again, we can see dolutegravir has shown better response compared to darunavir in virological suppression. Now, Downing study is a study which has taken into account whether it's a failing first line failed regimen. The alternate when patients were shifted to second line with dolutegravir based regimen or lopinavir, ritonavir with 2 NRTIs. So, important consideration in this study was that there should be at least 1 NRTI that is susceptible to the current NRTI out of 2 with having no mutations that specifically for the resistance of either of the 1 NRTI in that group. So again, dolutegravir supersedes from the PI based regimen in second line. So this is another trial, Nadia trial, which collaborates, which checks, it's a two-factor analysis, dolutegravir or darunavir compared with zidovudine and tenofovir. So we can see in few cases, when the CD4 count is less than 200, darunavir is shown to have better virological suppression compared to dolutegravir. Yeah, and among among the second line also, dolutegravir supersedes if the resistance is the resistant pattern is suggestive of if the resistance pattern, genotypic resistance has been properly analyzed and the proper NRTI backbone, one NRTI is there, which is susceptible. Then DTG versus darunavir, again DTG shows a better response compared to darunavir. So the weight gain is again a concern when we talk about INSTI, especially with dolutegravir. So we had this study was published in Clinical Infectious Disease in 2020. It has analyzed INSTI, PI, and NNRTI. So it has shown that the weight gain was significantly higher in INSTI group. In that too, bictegravir has shown even higher weight gain. So metabolic syndrome is usually a concern, deranged lipid profile. Sometimes we had seen cases when a patient with in the pre-diabetic cases and receives dolutegravir, unmasking of diabetes occurs and the patients started having raised sugar. So we have to keep in mind and counsel our patients about this, that we have a weight check has to be there, proper healthy diet and lipid profile and sugar controls has to be monitored. So this study again checked the mean weight again compared to DTG versus efavirenz, which is higher in DTG. Also, it was more commonly seen with the patients female patients, that they had a higher weight gain compared to the male patients in the same corresponding age group. TAF versus TDF, TAF also showed higher weight gain. So different single tablet regimens are available for the treatment-naive patients. So these are significant interactions. So we know that PPIs are not to be given when a patient is taking a PI-based regimen or a patient is taking an NNRTI-based regimen. But yes, it has less chances of having interaction when the patient is on INSTI-based regimen, which is nowadays the preferred first-line regimen. So NNRTI versus INSTI. So what are the possible role of NNRTI? So I had mentioned about that dolutegravir is superior in most of the studies and when it comes to virological suppression or increase in CD4 count, but still there are possible role of NNRTIs, especially when the patients are experiencing adverse events with INSTI, as I mentioned, and if the patient is experiencing weight gain with INSTI, this is again a conditional recommendation. Because we know that dolutegravir always performs better when it comes to compared to NNRTIs because of having high barrier of resistance. So, challenges with NNRTI use, lipid profile again increases with efavirenz, higher rates of virological failure. There are drug interactions also that are important in case when, especially with the rilpivirine group. So boosted PI regimen versus INSTI as first line is what are the current roles of boosted PIs. So if we are starting ART before the availability of the resistance data, it can be considered. But the problem is the poor adherence, and also a lot of drug interactions is being noted with PI based regimen, especially if the patients are also receiving ATT. Okay, so key take-home points. We have first-line ART regimens that are recommended by current guidelines, mostly INSTI-based regimen. Second-line ART regimens by current guidelines include INSTI and the PI-based regimen. NNRTI-based regimen is options for patients who have adverse events such as weight gain or intolerance to INSTI. And INSTI, PI, NNRTI all are playing equally significant case-based role in HIV management that you have to decide based on case-to-case basis. But yes, dolutegravir is always upper hand when you are starting with the preferred first-line regimen. So this is for the postgraduates. who all are the postgraduates here? Postgraduate students. I know it was a lot of theory here, but yes, you have to be alert. So this is a case of a 48-year-old lady who came on ART regimen. Somebody else started with TAF, FTC, and efavirenz. The dose of efavirenz is here 600 mg. Complaints of dizziness and depressive thoughts after starting ART. Her CD4 count at the time of initiation was 324 cells per microliter, and viral load 1,24,000 copies per ml. She visits you after 2 months of ART initiation and need your opinion. So what all you will suggest and what all you will look for? So straightforward, you are going to change it to DTG based regimen, or you will look for something else also there. How she is taking. So it is important how she is taking, because efavirenz, it is required to be administered empty stomach. It should not be taken with food because it increases the neurotoxicity of the efavirenz. Also, the dose I especially mentioned, it was 600. So first you can give her a chance that lower the dose of efavirenz to 400, which is now currently recommended. And even if she's not tolerating, then switch to DTG based regimen. One important point to be remembered that efavirenz has the enzyme inducing property, and so with DTG, if you are switching to DTG, it is important for first 2 weeks that you supplement the patient with additional dose of DTG to prevent DTG resistance. Okay, thank you.
Thank you for the wonderful lecture. Any questions?
Thank you, Dr. Ankita. You have given all the studies that were relevant to justify the use of DTG. So I would just like to summarize, because I see there are many non-HIV specialists here who are not treating many cases. So I would just like to simplify that DTG is the preferred regimen for various reasons you have told. It is a superior to efavirenz. It is superior to protease inhibitor-based regimen. It is superior to raltegravir. It is effective in those who are failing on first-line regimen also. The additional points are basically the viral reduction with dolutegravir is in 28 days compared to 84 days with efavirenz. That is a significant point because that is important in preventing transmission to the partner and to the child. Secondly, the point is that the discontinuation rate with dolutegravir is 2% compared to 12% with 7 to 12% with efavirenz. Third point you have highlighted is the resistance. Over 96 weeks of dolutegravir use, no resistant mutations have been identified so far. So these are some of the important points that we need to keep in our mind, and other points you have explained very well. Thank you.
Thank you.
I think we should stop here in the interest of time.
Thank you, ma'am. Thank you. I'll invite the chairperson for the next session, Dr. Mohit Bardwaj. He is a senior pulmonologist at SGT University in Gurgaon. And to present the case, I have Dr. Amit Kumar Chaudhary. He is a postgraduate student in medicine in FMRI.
So I am presenting the case of a 53-year-old gentleman from Sirsaganj near Agra. He is in business of making agricultural instruments, and he presented in the emergency with complaint of weakness, weight loss, and fever since last 10 to 15 days. On initial investigation, CBC was done when hemoglobin was 9.7, WBC count was less to 0.4 thousand, and platelet was 1.2 lakhs. HIV, as we have seen on the examination, patient was having the oral candidiasis and possible esophageal candidiasis, no oral ulcer, no skin rashes, and no nodules were there. So we have sent HIV, and patient came out to be HIV-1 positive, and his CD4 count was 5, viral load was 1.18 lakhs. Hepatitis virus, so HBs antigen was also sent. Anti-HCV was negative, VDRL was positive, CCT chest and abdomen was done, but that was normal, no lymph node and infiltrates was found. So patient was started on trimethoprim sulfamethoxazole combination and fluconazole. and he was advised for the admission. And we have sent the investigation, as we have sent the we have this can see the trend of the investigation. Initial symptoms on 20th, he was having the fever, hemoglobin hemoglobin was 8, TLC count was less, platelet, so it's showing the pancytopenia. And on even after repeating the test, we have found that patient is now having the complaint of vomiting, and the pancytopenia is persisting. So with the trimethoprim, and with we have also added the fluconazole, but after the complaint of nausea and vomiting, we have stopped the fluconazole. And blood culture sensitivity shows like a coagulase negative step, but and we have, instead of after stopping fluconazole, we have started anidulafungin, and antiviral therapy was started. After stopping this ceftriaxone, as the patient didn't show any response, so we have changed from ceftriaxone to imipenem, and we have continued. We have now again started fluconazole and CMV DNA, and that was also sent. Patient showed the 900 copies per ml. That's not that significant. So patient is having this with HIV positive and persistent pancytopenia. So what can be the differential in that case? So we can divide the differential, like if it can be causes, can be the infectious causes, malignancy, autoimmune, nutritional, and there can be the other causes. So one by one, if we go like infectious causes, so a patient with acute febrile illness, patient can have dengue, malaria, enteric rickettsiosis. As in my case, in patient, HIV itself can cause the pancytopenia. So even the sepsis, tuberculosis, brucella, leishmaniasis, invasive fungal infections also can cause the pancytopenia. HLH, that secondary HLH, primary HLH in itself can cause the pancytopenia. Cytomegalovirus that can cause pancytopenia, but in our case that it was negative. If we go for the malignancy, so AML, lymphoma, and myelofibrosis that can cause pancytopenia. And autoimmune causes, if we see the SLE. If we go for the nutritional causes, then the vitamin B12 deficiency, folate deficiency, and copper deficiency can cause the pancytopenia. But other causes, if we see alcohol, say, chronic liver disease, hypersplenism, that can cause the pancytopenia. So peripheral blood smear was also sent. So in this smear, we see the cells that containing the budding yeast, as we can see. The budding seed, macrophages containing the budding seed, and after that patient was started on amphotericin B, and subsequently itraconazole were started. As we said that histoplasma in the previous slide, we can see that budding yeast of the histoplasma that was confirmed by the hematologist when we have sent the peripheral smear. So we have started on this amphotericin B and itraconazole. And after starting this medication, patient improved symptomatically. And again, when we have repeated the CD4 count in the February, after 15 days, the patient came out to be CD4 count also improved. So in this case, what are the issues? Like if histoplasmosis, in many cases, we are not suspecting like histoplasmosis in HIV patient, as HIV itself can be the cause of the pancytopenia. So we are not going in that direction. But after seeing the smear, we have started this amphotericin B and itraconazole, and we have seen the significant improvement in the patient. So the issues are like, is histoplasmosis is very uncommon, or we are uncommonly identified? As we are seeing that cultures in, we have seen the many studies, the cultures are almost negative in many cases and all. So is that there is any rapid test or that which is available? So if we see that a few years ago, there were no rapid tests were available. But now if we see that, yes, answer is yes, that there is rapid test is available. There is now in case of histoplasma capsulatum, lateral flow assay is available that we will discuss in the next slide. But when we see the epidemiology in India and also in UP, Punjab and West Bengal, in all these cases, we see that these are the endemic areas where we see the histoplasmosis cases. But now it's not that these cases, histoplasma is common only in these endemic areas. Now we are seeing that few cases are coming from Rajasthan and other areas also. So there was in epidemiology, when we see in which cases we are finding that if the patient is person is having the significant occupational exposure to soil and is having with the exposure to birds, and also in these cases we are finding these cases. And one significant point is that histoplasmosis is more common in male in comparison to female. So there is that beta estradiol in women is protective against histoplasmosis, as that it is stopping the effect of mycelia to transformation into yeast. So it is helpful, and also it is helpful in increase the secretion of Th1 cytokine. So there is one study as also by Dr. Neha. So I have seen the reference from that study that histoplasmosis cases in North India that was done, and in that case 21 patients with proven histoplasmosis were studies, 18 were male and 3 were female, as we have also seen that more common in male. So 7 patients from UP, 6 from Haryana. These are the Haryana, Chandigarh. These are the endemic areas, but patient also came from Rajasthan, Himachal Pradesh, Bihar and Assam. So 7 patients out of them, 7 patients having the diabetes, and 4 were with the HIV, and 3 were having the chronic liver disease, while 7 patients were having no comorbidities. So 12 of the patients, usual presentation of the histoplasmosis with pyrexia of unknown origin, they came with and they also presented with the weight loss. And also 2 of them presented with the oral candidiasis, as in our case, patient also presented with the oral candidiasis, and 2 patients presented with the cervical lymphadenopathy. Majority of the patients, when we have done the CCT chest abdomen, and in the CCT abdomen, we have seen the majority of the patients were having the adrenal involvement. 2 patients were having the lung lesions, and the lymph node involvement was also present in 2 patients. So in these cases, histoplasmosis were proved by the biopsy samples, and but when we talk about the culture, in all cases culture were negative. So 9 patients received combination therapy with liposomal amphotericin B and the itraconazole, and out of the 20 patients, out of 21 patients, after starting this therapy, they have recovered well. Unfortunately, one patient died because he had the aortic involvement. So this is that test we were talking about, the lateral flow assay test that is available now, and it is the 15-minute test. It is card-based test. So now we can use, now this test is available, so it is easier for us to diagnose, and we can do this test. For this test, there is the sample requirement is that we have to give the patient 8 hours fasting, and midstream it is urine sample is needed. So midstream urine sample should be collected, and the specimen should be collected at the room temperature. So what is the conclusion? So that if the patient is a HIV patient, and after starting with the antiretroviral therapy, patient is having persistent pancytopenia, so it's important, we should suspect about the histoplasmosis also. So histoplasmosis, as we and the presentation is also with the, it's like TV, it presents. So we have to persistent cytopenia cases we have to suspect about it, and issues now we have to establish more mycology laboratories so we can diagnose these cases and all. Thank you.
I think Dr. Amit presented a very good presentation, and if there are any questions from the audience, they can ask.
Yeah, that's a good presentation. I have an observation and a question also. You had a very low CD4 count
Yes.
Did you do a serum crack before you started fluconazole?
Fluconazole,
Serum cryptococcal antigen. Did you do a serum cryptococcal antigen before?
this
See, because if you add fluconazole without doing with such a low CD4 count, you can do an unmasking iris, especially of cryptococus. Other thing is, it's of curiosity, please.
Yes.
You showed a good slide. I didn't understand. You said peripheral smear? Okay. So it's actually new to me. I really have not seen any peripheral smear histoplasma. I've seen more in the tissues or in bone marrow.
So the interesting part was that this patient had just presented with pancytopenia and there was no adrenal involvement, there was no lung involvement which was seen here. And this patient, the credit goes obviously to our hematopathologist. Once we started the antiretroviral therapy, there was a increase in the, a little increase in the fever, and the then subsequent peripheral smear showed the budding yeast cells. And this was the diagnostic clue on this. They were single encapsulated yeast. And this is in fact one of my first cases of peripheral smear where the diagnosis of histoplasmosis was made. Otherwise, obviously, we see it more on the EUS guided adrenal biopsy is the mainstay usually for the diagnosis.
No, I just wanted to thank for this presentation because in national program, there are almost 1.4 million people on ART. And there are hardly 10 to 15 cases of histoplasmosis reported because you're not suspecting, first thing. Secondly, there was no rapid test kit available. So that was a good information.
Yes.
Thank you.
Yeah. So we recently have this lateral flow assay, which is available, which can be used for the diagnosis of histoplasmosis. And it's a very rapid test as well. Gangaram has it. I think Dr. Jatin Ahuja has also started, and we will also be starting it in Gurgaon as well.
Good evening. I must congratulate the postgraduate resident for a presentation. Probably it's his first presentation in life. So I must congratulate him and congratulate the mentor for giving him an opportunity to be. So let us cheer for him. It is probably his first presentation and we have to congratulate him sitting on the stage, standing in front of the leading ID physicians of the country and speaking about a case and answering probably the questions.